the membership increased from 19 to 54. The theme of the meeting was disorders of the lumbar spine. From there, we have come a long way. 25, 35 years later, we are doing our first virtual Assicon. We have grown from a body of 19 members to around 3,000 members now. It is said that the strength of a conference comes from the amount of free papers the conference receives. This conference has a full house. We have 7 VTI gold medal papers, 70 accepted free papers, short 30 free papers, and 85 posters. And we are collaborating with the Argentine Spine Society and the German Spine Society as the guest faculty for this conference. We have a galaxy of stars from all around the world, and they need no introduction. 34 foreign faculties joining us for this conference. And then we have this special session. The Assicon offers you even more, and you meet one-to-one with these spine legends, including our own Vijay Lahiri sir, Ingal Alikar sir, Dr. Lawrence Lenke, Michael Fellings, Boreani, and others. I would like to welcome our chief guest for today, Professor Dr. Sunil Kumar, who is the Director General of Health Services. Welcome, sir. I will also like to welcome Dr. Juan Pablo Bernasconi, who is the President of the Argentine Spine Society. Thank you so much for joining us, sir. I would also like to welcome the President of the German Spine Society, Professor Linenquist. Unfortunately, he is not able to join us physically today here, but he sends his best wishes, and he's going to be with us in all his lectures in his conferences. So he's going to be with us. Also, it's my proud privilege to welcome Dr. Professor Kyu-Cheng Cho, who's the President of the Korean Spine Society. And a lot of ASSI members have been very closely associated with Korean Spine Society. Just to finish my welcome address, I would also like to welcome our beloved President, Dr. H.S. Chabra, and the dynamic Joint Secretary, Gautam Zaveri, sir, to take over the proceedings of this inaugural ceremony of the first virtual Assicon 2021.
Like any conference in India, we always start the conference by invoking the blessings of the Almighty on the conference. So can we have the Saraswati Vandana, please? Again, welcome on behalf of the President, Dr. H.S. Chabra, my colleague and friend, the Secretary of the Association, Dr. Ajoy Shetty, the Executive Committee of the Association of Spinal Surgeons of India. I would like to welcome each and every one of you to this conference, Assicon 2021. It gives me great pleasure to have the President of the Spine Society, Dr. Cho, the President of the Argentinian Spine Society, Dr. Berlusconi, and a message from the President of the German Spine Society, Dr. Lindquist. So, just for the information of our visiting presidents, I would like to share some information regarding the Association of Spinal Surgeons of India. Association of Spinal Surgeons of India, as just told to you by Ankur, is one of the oldest spine associations in the world. It started way back in 1985 with its first conference being held in 1986. Today is its 35th conference, and from a fledgling body of 19 members when it started, today we are a vibrant body of 2,772 members. This time, for the first time at Assicon, we have a combined meeting with three different spine societies: the German Spine Society, the Society Argentinian for the study of pathology of the vertebral column, that is the Spine Society of Argentina, and the Korean Spine Society. We are having for the first time a collaboration with Spine 20, which is an advocacy group among G20 countries regarding spine. And that session is called Spine Surgery, Navigating the Future. We also, for the first time, have arranged interviews with legends in the field of spine surgery, whose contribution is monumental to the development in this field. We all will take experience and learning from these legends, including Lawrence Lenke, Stefano Boriani from Italy, Michael Failings from Canada, Professor John Lowenstein from USA, our very own Dr. Atul Goyal and Dr. Vijay Lahiri from the KEM Hospital in Bombay, and our founding secretary, Dr. V.T. Ingalhalikar. We also, as a part of the Assicon, for the first time collaborated with the Indian Medical Association, the Federation of Family Practitioners Association of India, and the General Practitioners Association of Greater Bombay to hold a CME, a master class on spine problems for family practitioners, for which we got fantastic feedback from the family practitioners. This afternoon, we had a community awareness program on preventing spinal injuries and back pain, which was tremendously appreciated by the Assistant Director of Health Services, India. This year, we have interactive case discussion sessions, video sessions, and of course, our routine lectures and plenary sessions are also there. For the first time at Assicon, besides the members of the Argentinian Spine Society, the Korean Spine Society, and the German Spine Society, we had a host of almost 25 other faculty, and the guest orator for this year is none other than Dr. Douglas Brown, whose contribution to spinal cord rehabilitation and injury is very well known. Before I end this talk, and let me invite all of you for a virtual cultural evening on Sunday, the 31st of January, between 6:30 p.m. onwards, the link for which will be shared for you. For the knowledge of the presidents of the other associations, what are the other activities of the ASSI? This year, we have almost 840 registrations. We launched recently an online e-learning tool for spine surgery. Throughout the COVID period, we ran webinars. We have a monthly video journal. We have case discussion forums, fellows teaching programs, and fellows exams. We participated in Spine 2020, and also we were invited, thankfully, to the Korean Spine Society meeting. We have long-term observerships and recently have started 5 new short-term observerships. ASSI has also come up with a number of publications. About 8 years ago, we published the book on spinal infections and trauma, the chief editor of which was none other than our very beloved Dr. Rajsekharan. 2 years ago, we came up with a series of 8 monographs on various topics in spinal surgery, and these have been sold and marketed through our platform in medical publishers, the TM. ASSI also comes up with a biannual spinal journal called as the Indian Spine Journal, and we would love to collaborate with the Korean Spine Society and the Argentinian Spine Society for articles in this journal. As I mentioned earlier, ASSI is growing in strength, and to follow ASSI, one must follow us on our website. We also have social media platforms such as a Facebook page, a Twitter handle, and YouTube channels. Almost all our webinars and the video journals are already available on the ASSI YouTube channel, and they can be accessed through our website. Now, without much ado, let me pass on the baton back to Ankur and welcome each and every one of the delegates, each and every faculty, moderator, panelists, and all members across the world who are watching us today on these open sessions or special sessions, as I would call them, where we are going to have a very interesting and exciting program. Collaboration of Argentinian Spine Society, collaboration with the German Spine Society, as well as the journey with the legends of spine surgery will all be telecast across the world free of cost with free registration. Thank you very much.
As is our tradition, we'll be playing the ASSI anthem now. Can we have the ASSI anthem, please?
Organization of scientists with human mind. ASSI, ASSI, ASSI. ASSI is one of a kind. Organization of scientists with human mind. ASSI, ASSI. Members from north, south, east and west, we are as best as in east and west. Modern and traditional blend at best. We keep in mind patients' best interest. Members from north, south, east and west, we are as best as in east and west. Modern and traditional blend at best. We keep in mind patients' best interest. ASSI, ASSI, ASSI is you will find. Organization of scientists with human mind. ASSI, ASSI. All of us are doing, let's do it better. We follow our aim to the letter. Patients can get it now.
first, good fun later. All of us are doing, let's do it better. We follow our aim to the letter. Patients get getting now better and better. High academics first, good fun later. For all of us, ASSI is matter of pride. Organization of scientists with human mind. ASSI, ASSI.
ASSI is one of a kind. Organization of scientists with human mind. ASSI, 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 ASSI.
We move on to our next presentation. Can we have Dr. Ulf Liljenqvist's welcome address speech, please?
Ladies and gentlemen, dear colleagues, dear friends and members in the Association of Spine Surgeons of India, it's a great honor and privilege to give a brief welcome address. My name is Professor Ulf Liljenqvist. I'm an orthopedic spine surgeon from Germany, and I'm the current president of the German Spine Society. And as I heard that your association is quite an experienced association, you were founded back in the 80s. Our society is quite young. We were founded back in 2006. And our society is an interdisciplinary society consisting of neurosurgeons, trauma surgeons, and orthopedic surgeons. And starting from a membership number of about 500, we have grown tremendously. Now we have around 2,500 members. And by that, we are the largest spine society in Europe. We have annual meetings at the end of the year, and we normally have more than 3,000 people or attendees coming to that meeting. And this is always a very interactive and joyful exchange of knowledge and science. So we are very proud and very glad to be invited to collaborate with the Association of the Spine Surgeons of India and to contribute to the success of your society. And we will have a session on Saturday and discuss various topics and even have an interactive discussion on further collaborations with you, for instance, like fellowships or grants or scientific collaborations and projects. So I do look forward to that very session, and I wish you all the success for that annual meeting, and we do look forward to further collaborations. Thank you very much.
Thank you, Dr. Liljenqvist. May I now request Dr. Juan Pablo Bernasconi to say a few words. Welcome, Dr. Bernasconi.
Hello, and really thank you very much. I am the current Argentinian Spine Society president, and of course, this is it's great to be here with you. It's a pleasure for our society. Our society, the Argentinian Spine Society, is the oldest society in South America. Was founded in 1966, so we have around 45 years old, and we are around 400 members in not only in Argentina, also in the rest of the country around our country, especially members from Bolivia, Paraguay, Brazil, Chile, etc. So it's a very important society, and also we are doing since 45 years a very interesting process to arrange the different surgeons to the different categories. And also we do each year a special event and a special meeting with different guests. So be here with you is a fantastic opportunity to us. since the last year, we are trying to join into the international spine surgery community. Sometimes it's pretty hard because our country is not in the best position in the world, and it's changed a lot. So to try to think to future, sometimes is pretty complicated. But we are trying from our society, and this is a fantastic opportunity to join together and to do together the different steps. So thank you very much. A great pleasure and a great honor for myself and also for our society. Thank you.
Thank you so much, sir, for your thoughts, sir. We completely agree with you. If something positive has come out of this COVID pandemic, it's something which has been that it has brought the world together. It has brought all of us together. May I now request Dr. Cho's welcome message to be played. Dr. Cho is the Korean Spine Surgery Society President. Welcome, Dr. Cho. Can you play his video, please?
Good evening. I'm Gyujung Cho, President of the Korean Society of Spine Surgery. I'd like to thank President Dr. Chahabara, President-elect Dr. Acharya, and Dr. Joy Shetty, and Dr. Kwatman Jabari of the Association of Spine Surgeons of India for inviting me to this excellent meeting. I would also like to extend my sincere congratulations to you on the opening of Assicon 2021, which sets the stage for sharing diverse perspectives on spine surgery, as well as promoting knowledge exchange among scholars that brings together distinguished participants from home and abroad. It must have been challenging to host this event in the midst of sustained COVID-19 pandemic. COVID-19 has brought difficulties to the economy, society, as well as international relations, and spine surgery is no exception. As we work together to overcome the challenges, the theme of Assicon 2021, the future of spine care, feels timely indeed. I believe this will be an opportunity for us to contribute to innovative development of spine surgery and explore the future by overcoming the crises and uncertainties in the face of post-COVID era. Korean Society of Spine Surgery are taking part in Assicon 2021 as presenters and speakers to contribute to its success. I'm convinced that the collaboration between the Association of Spine Surgeons of India and the Korean Society of Spine Surgery will create future opportunities to promote spine surgery in Asia Pacific area and international academies. I would like to take the opportunity to let you know the Korean Society of Spine Surgery will be hosting International Congress of Korean Society of Spine Surgery on May in Seoul. I look forward to your interest from India. Mahatma Gandhi once said, "Speed is irrelevant if you are going in the wrong direction." Amidst the crisis, we must work together to propose a new vision and shape a new environment that will positively impact research activities. I hope Assicon 2021 will enable us to set a new stage for knowledge exchange in spine surgeons and to map out the future direction for positive cooperation. Once again, congratulations on the opening of Assicon 2021, and I extend my best wishes for the success of the conference. Thank you very much.
Thank you, Dr. Cho, for a nice message, and we really look forward to participating in the conference in South Korea. And I'm sure all the members from ASSI will participate in huge numbers.
You are welcome.
It's now my proud privilege to invite our president of ASSI, Dr. H.S. Chabra, to deliver his welcome speech.
Thank you, Ankur. I would want to extend a warm welcome to all of you on behalf of the Association of Spine Surgeons of India. This Assicon 2021 virtual is the first virtual conference of the society, first virtual Assicon of the society, even though we had a virtual conference in September, but that was not a regular Assicon. And it is our privilege to have some of the leading societies with us and their representatives here with us, including those from the Argentinian Spine Society, the German Spine Society, and the Korean Spine Society. And it is our privilege that they've been able to address all of us, which symbolizes the strong relationship that we have with them. A warm welcome also to all the international and the national faculty, and to all the delegates who are there for this virtual conference. Of course, we are still awaiting our Honorable Director General of Health Services, Professor Sunil Kumar, who got busy with some official engagements, today being the first day of the budget session of the Parliament, and with COVID being the hot area of discussion, he probably has been summoned, and he has messaged to me that he'll try to join, if possible, during this inaugural ceremony. But he extends greetings to all of you. Of course, his representative was there with us for the launch of the Injury Prevention Community Awareness Program that we have launched today, and the first initiative that was a panel discussion on the way forward that we had earlier in the day, when the additional DG, Dr. Tanu Jain, joined us for the event and shared with us the initiatives being taken by the Government of India in this regard. I would want to share with you some of the various initiatives that are being taken by the association. And amongst the first of them is the strategic plan, which the Association of Spine Surgeons of India has conceptualized. We have had a review of the strategic plan. We have done a priority matrix. We have had a relook into the vision and mission of ASSI. The vision of ASSI reads as to be the leading pioneer association in spine and neurosurgeons division to promote healthcare service delivery to the spinal ailment community. ASSI aims to become the most preferred organization for training, research, community outreach, academics, comprehensive care and treatment of spinal disorders to advance the well-being of the people of India and beyond. So in this, we have tried to think beyond 2020 and have a roadmap for ASSI for the next 5 to 10 years in various areas like conducting research on innovative approaches in spine treatment, taking responsibilities even in unprecedented situations like COVID-19, spreading awareness via e-learning facilities, bridging the gap between theory and practical work, planning team-building activities unrelated to work, and conducting ground-level social initiatives. The strategic plan has various priorities, and for each of these priorities, various initiatives have been listed, and the priority matrix for all of these are being worked upon by the executive and will be shared by the members soon. Among these are streamlining activities and organizational structure. I have only highlighted few of the initiatives that are there in the strategic plan. These are some of the important initiatives: scientific activities, training and service development, development of educational material, networking and information exchange, research, and advocacy. And in fact, amongst these initiatives, some of them were in the operational plan for this year, and which we have implemented despite the COVID-19 pandemic being there. One of the most important ones was, as I discussed, injury prevention awareness program, and for which we did a launch today, as mentioned earlier, and we will be taking this movement across the country, involving at least 20 cities, and at least members from each of them will reach out to at least 50 schools, colleges, organizations, industry and community organizations in order to spread information about awareness to them. The other initiative that we have taken this year has been the capacity building and excellence in spine surgery program, which we have launched in the Adani Institute in Bhuj in Gujarat with the help of mentors from ASSI. And of course, even though COVID prevents our mentors to be there, they continue to exchange their views on WhatsApp, mails, and we are trying to have virtual reality providing guidance to them from the mentors as such. We have also taken various initiatives like having a task force for the COVID-19 together, and Dr. Bhavuk Garg has been instrumental in carrying these activities forward. To know about these activities, you could just log on to the website of ASSI and see the COVID-19 task force page on the website. We have also tried to develop educational materials that contain specialized modules based on different aspects in spine in the form of a web resource, ASSI elearnspine.org. We have had various modules compiled which are already live, and look forward to the video library where very important experts, very renowned experts will be contributing various videos. This you will be able to see soon. We have also, under the networking and collaboration priority, we have worked on the initiative of developing national and international partnerships. And in the national partnerships, we have tied up with 8 other societies which also deal with injury for the injury prevention program. And for the international partnerships, you have in front of you how we have been able to get various societies together with this initiative of disseminating information to all concerned. So we thank all the societies and their presidents who are there with us, the Argentinian Spine Society, the German Spine Society, and the Korean Spine Society. A big thanks to you. Of course, to achieve all these initiatives, it is very important to have teamwork, to grow together. As Brandon Nambard said, I water you, you water me, let's grow together. And without this, we will not be able to achieve what we have in plan for the next 5 to 10 years. So the society members should talk and identify the value of a teamwork culture. The executives should model teamwork in their interaction with each other and the rest of the society. The executive leaders should communicate the clear expectation that teamwork and collaboration expects, and we should build fun shared occasions into the society's agenda. So as they say, together everyone achieves more. The achievements of an organization are the results of the combined effort of each individual, as mentioned by Vince Lombardi. And we are very lucky to have a wonderful team here, a wonderful team which has all the experience of the senior members, all the past presidents, including our founder and mentor, Dr. V.T. Engel-Halikar, to all the past presidents of the Association of Spine Surgeons of India, to all the past executive, the present executive, the co-opted members, and of course, very importantly, all the members of the Association of Spine Surgeons of India. And this wonderful team will work together to achieve more and more for what is our mandate, bringing relief to people with spinal ailments. And very important to involve young members, which is very important to uplift the association in new dimensions with their new vision, to boost the core strength with new energy and great synergy, to lead the next generation with core values and new methods, and to volunteer in social activities with zeal and zest. And we are proud to have a lot of young members who are very active. And in fact, what you see today, Assicon 2021 virtual, is being run by a large number of these young members. Of course, I would not want to forget the role of the Secretariat, which is very important in contributing to the growth of ASSI, and also the IT team here at ISIC, which has been like a pillar in all our virtual activities. So I'd want to thank them from the core of my heart for the wonderful work they've been doing. So this wonderful team will deliver the result, and as we work to create light for others, we naturally light our own way. And this holds especially true for us at ASSI. So with these words, I would want to welcome you all to Assicon 2021 virtual. I think I forgot to mention the name of our President-elect, Dr. Shankaracharya, who takes over as the President tomorrow. I would apologize for any shortcomings from our side that you would face, but in the interest of what is our mandate, we would move forward, forgetting all mistakes. And of course, the technical glitches which have been there. Long live ASSI. Jai Hind. Thank you.
Thank you, Dr. Chabra, sir. It is your inspiring words always inspires us to do better. May I invite our President-elect, Dr. Shankaracharya, sir, to say a few words of encouraging?
Good evening, everyone. I welcome all the ASSI members. I welcome the presidents of the Korean Spine Society, the Argentinian Spine Society, and German Spine Society. I know Ulf Lillenquist is not here, but I actually trained under him and I did a fellowship with him in Munster. So it's been a long time since I've seen him, and it's a pleasure to see him. Dr. Chabra has actually laid out very well how he has programmed ASSI to move ahead for the next 5 to 10 years. And everything looks well set for me and easy for me. And with his center being the ASSI headquarters and with him in the background, it should not be a difficult task for me, I suppose. But I'm going to work very hard with the whole team and take everything that he said along to a higher success. Dr. Chabra and I go back long together as we were students in training in Safdarjung Hospital way back in 1989. But now he's like my big brother to him. And though I may look a little older today, I'm like a younger brother to him. So I welcome all the members. I welcome all the task force members that Basu set up initially with Chavra, and then they created a teamwork, and each of the task force members have worked tremendously hard, including the ones that Raghav initiated. And this whole thing has become a big family with very good bond together, and we are working together to make it a best organization. As Chavra said, the organization that everyone will look forward to treatment of spine ailments, disorders, training, initiation, education, and community service. Thank you, Chavra. Thank you, everyone. And thank you for giving me this time to speak a few words.
Thank you, Shankar. Ankur, I take the privilege of being the president to, of course, thank Dr. Shankar Acharya, who takes over tomorrow. But we know that he lost his father very recently, and we extend condolences to him. He always looks very young, but because of the ritual, he couldn't shave his beard. And that's why he may have a look which may make him say he looks older, but he is always young. But since we haven't been able to have our DGHS join us still from his official commitments, Ankur, I'm taking the privilege as president to request our founder, Dr. V.T. Angal Halikar, who is like a father figure to all of us, to address this gathering. Thank you, sir, for being there for the society and for giving birth to the society and taking it to what it is right now.
Thank you, Dr. Chavra. It's indeed a moment of pride and fulfillment for me. We not only are grown ourselves, but we have grown friends amongst all international societies. And the very fact that 3 international reputed societies have collaborated with us, they are with us, their members are doing presentations in our meeting, itself speaks about the credibility that Association of Spine Surgeons of India has all over the world. What started as a very small, tiny effort to concentrate learning spine surgery with an aim or with a vision that all of us are doing it, let's do it better. That was the motto with which we started. And all my successors in these years have taken the ASSI from a small little tree or small little bush to a huge tree under whose shadow or shade people come for relief of their trouble. Amongst all the societies in India, ASSI is one of the most education-oriented society. The amount of courses, the amount of teachings, the amount of workshops, the amount of fellowships we do are tremendous. And I am not aware of any other, as a society, individual institutions, yes, but as a society, perhaps not. So, in fact, I am thankful to all my followers, including a lot of youngsters, a lot of young live wires who have brought ASSI to this level today. And it's a really, indeed, a moment of fulfillment. What I wanted to do something in life, I have achieved, and there's nothing more I want to achieve in life now. And I once again thank you all. I thank all 3 international society presidents that you people agreed to our invitation of joining us. You people have brought real grace to this congregation. I thank you all again. Thank you, Dr. Chavra. Thank you, Dr. Shankaracharya. God bless you all.
Thank you, Dr. Ingalalika, sir. Your blessings and your words always guide us to do better and better and take ASSI to newer heights. Now, with the permission of the President and the President-elect, I would invite my dear friend and colleague, Dr. Neeraj Gupta, to do the privileged task of giving the vote of thanks.
Good evening, all. I feel honored and privileged to get the opportunity to propose a vote of thanks on this special day. I take the opportunity to put all my gratitude into words. On behalf of Association of Spine Surgeons of India, I convey my regards and hearty thanks to our Chief Guest, Director General Health Services, Dr. Sunil Kumar, for taking time off from his hectic schedule to be with us today. At the time when COVID pandemic started, no one could imagine of doing an annual conference on such a large scale. I'm happy to announce that Assicon 2021 Virtual is being attended by more than 1,000 delegates from around the world. This itself is a huge success for any meeting. We are proud to say that this year we have opportunity to have combined sessions with 3 international societies, which are participating wholeheartedly to make this event a huge success. My sincere thanks to esteemed members of Argentine Spine Society, German Spine Society, and the Korean Spine Society, who will exchange their valuable ideas with us, which would definitely help to create a better future for spine surgery. We are thankful for your enthusiastic and meaningful participation in the meeting. I thank all the plenary speakers for giving us words of wisdom. We are humbled and thankful to the legends of spine surgery from all parts of the world to be part of this meeting. I would like to thank all the patrons and past presidents of ASSI, under whose guidance we all are grooming to become each day better. At this point, I would also like to thank all the Indian faculty who have come together to make this event successful. I acknowledge and thank from the bottom of my heart the unwavering support received from the President of ASSI and Organizing Chairman of the conference, Dr. H.S. Chabla. My thanks and regards to President-elect and Co-Chairman of the conference, Dr. Shankaracharya, for always guiding us. I have no words to thank the organizing secretaries of the conference, Dr. Ajoy Shetty and Dr. Gautam Zaveri, who are the torchbearers of the event. They have worked relentlessly in conceptualizing this program. I wish to acknowledge the untiring efforts of the young, enthusiastic, and vibrant organizing committee and executive committee of SSI, who were the real workhorses in implementation of all the decisions in this meeting. They handled the conference with utmost professionalism. It would not have been possible without them. It's my duty to thank the secretarial staff, Ms. Neema Vish and Ms. Meenakshi Mohan, who always work tirelessly in making this meeting a great success. I would also like to thank our digital partners, Grover Audio Visuals, for the virtual platform, and event manager, Alpcord Network. At this moment, I would like to thank Deepak ji and Milan ji. Also, I would like to thank our web designer, Ravindra Bharti. I am very much thankful to all the industrial sponsors of the conference. I would be at the fault if I missed to acknowledge anyone else's contribution. But ASSI thanks each and every one of you in making this event a huge success. At the end, words are not enough to thank all the honorable delegates who blessed us with their presence. No conference can be successful without the active participation of delegates. I wish you all a great and enlightening academic feast in the coming 3 years. Thank you.
Thank you, Neeraj. This brings us to the end of the inaugural ceremony. And as is the tradition, we will end the ceremony with the national anthem. So I would request everyone to stand up in their places.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
This brings us to the end of the inauguration ceremony. We have a very dynamic session lined up. We have the Argentine Spine Society combined session with Association of Spine Surgeons of India. And it's my proud privilege to invite Dr. Gautam Zaveri, who's moderating this session, to take over the proceedings of the session.
Am I unmuted? Can you hear me now?
We can, sir.
Yeah.
Yes.
Yeah. Good evening, ladies and gentlemen. Let me welcome all the delegates from the Association of Spinal Surgeons of India, delegates from our friends and neighbors, the Bangladeshi Spine Society, the Spine Society of Nepal, the Spine Society of Sri Lanka, the Egyptian Spine Society, the Korean Spine Society, and members from the participating associations, that is the Argentinian Spine Society and the German Spine Society. Today, we have people from all across the world who have joined us for this special session and are looking forward to the interaction between and learning from the interaction between our two societies. Let me take this opportunity to welcome our guests. You've already heard from Dr. Bernasconi, the president of the Argentinian Spine Society. Along with him, we have a very, very experienced, knowledgeable team who is going to share their knowledge, experience, and help further this program. Today, we have with them the ex-president of the Argentinian Spine Society and a very close friend of mine, Dr. Marcelo Grunberg. We have Dr. Gaston Camino, Dr. Matthias Petracci, and Dr. Joan Emerich. All of these people are enormously experienced in the field of spine surgery. And if you look at their curriculum vitae on Google, it will seem to be believed. Just to introduce the ASSI to our people, in India, we traditionally welcome anybody with folded hands. It is called as Namaste. So let me start by wishing the Argentinian Spinal Society members a big Namaste from the entire ASSI over here. ASSI is a body which started in 1985 with 19 members. Today, it has 2,772 members. We have grown on the shoulders of these giants who have led the society over the last 35 years. Today, we have 1,000 members who have registered to see the program online and participate in the program. What are some of the activities that ASSI does? We have biannual conferences. We have a main conference which is called as the Assicon, and half yearly we have once in a year we also have the instructional course lectures. ASSI under the leadership of Dr. Chhabra has developed an e-learning tool which will be useful for both the common man as well as to orthopedic surgeons or spine surgeons or neurosurgeons who wish to further their knowledge on spine. Over the COVID pandemic, we have been doing regular webinars. We have come out with a monthly video journal which aims to bring evidence to our clinical practice. We have launched a case discussion forum. Today, there are about 600 doctors from all across the world who are connected to us through this case discussion forum. There are 384 cases which have been fully worked up and uploaded, and there is active discussion. We have short-term and long-term fellowships, and that is something which we would like to do and share with the Argentinian Society. An opportunity for your young doctors to come to India and for ours to come there and learn from all of you. Other activities at ASSI. ASSI has been doing multi-center trials. The first set of multi-center trials is just coming to fruition, and hopefully there is some exciting and new data which is going to come up and be published over the next 5 or 6 months. ASSI has a spine registry. More than about 5,000 cases are put up on the spine registry, and it is completely worked up and actively being followed. ASSI does outreach programs where we go to second level and third level cities in India to try and spread the message of safe spine surgery across our country. A social wing is established which helps conduct free camps, not only clinical camps to examine patients or teach exercise, but also surgical camps in small villages and towns across India where patients are either not affording or are unable to access tertiary level care. We have also started in India, because of the poverty and sometimes because of the lack of access, children come to us very late with scoliosis. And therefore, to prevent this problem, we have started a scoliosis screening program which is working actively. ASSI, again, as I mentioned earlier, has multiple publications. Dr. Rajsekharan was the editor of the ASSI textbook on infections and trauma. It is still available through JP Publishers and on Amazon. 2 years ago, we came up with a series of 8 monographs on specific topics in spine surgery. These monographs were published by TM Publishers and are available again through Amazon or through the TM website. We have a biannual journal called as the Indian Spinal Journal, and we would be happy to collaborate with the Argentinian Spine Society to see if we can reciprocally get papers from Argentina to be published in this journal. If any of you from across the world are interested in following ASSI, you can follow us and join us on our website. All this information is there. All the webinars, the video journals, etc. are available as links from our website. You can also follow ASSI on our Facebook page, the Twitter handle, and we have a YouTube channel which is screening this live. Without much ado, let me welcome again all 5 members of the Argentinian Spine Society and all the delegates from across the world who are watching the program today. What is the program now? The first session is composed of lectures. We start with lectures. We intersperse between the Indian faculty and the Argentinian faculty. And thereafter, we have a very interactive case-based panel discussion, which should be exciting. And after this, at the end of this, we have a meeting or what is called as a journey with the legends. Legends of spine surgery, Dr. John Lowenstein, scoliosis surgeon from the US, Dr. Lawrence Lenke, another scoliosis surgeon who needs no introduction, and Dr. V.T. Ingalhalikar, our founder president, will all be interviewed and will be a great learning experience on various aspects of their professional and personal life, which will teach us how we could go ahead with us. So now let me invite the first speaker, or before I invite the speaker, let me invite the moderators for this session, Dr. Marcelo Grunberg. Good morning, Marcelo. I thought I had lost weight, but you seem to have lost double of what I have lost.
Good morning, Gautam. It's a pleasure. It's very nice to see you again, you and all our friends there in India. Really, the meeting, the scientific meeting didn't start yet, but I have already learned a lot in the way you handle this, the spirit you give to everything. So I am honored, I'm proud, and I'm sure you are going to have an outstanding meeting. Thanks again for the invitation, Gautam. Thanks, Raja. Thanks, AJ.
My friend and colleague, Dr. Ajay Shetty, is unable to make it today. I will be replacing him as one of the moderators, and I don't see Dr. KV Menon come in. Can I request Dr. Srivastava to join us as a moderator for this session? And without much ado, can I request the AV team to invite Dr. Vishal Kundnani to make his presentation on pediatric transarticular C1, C2 fixation techniques, pearls, and pitfalls.
Thank you, Dr. Gautam.
Vishal Kundnani is a dynamic spine surgeon from Bombay, one of the young, upcoming, and brightest stars on our horizon. So let us hear from Vishal.
Thank you, Dr. Gautam. I welcome
everyone and welcome to Assicon 2021. Transarticular screw fixation has proven its efficacy as one of the most stable and reliable method of fixation in reducible C1C2 dislocations. The challenge lies in the pediatric ones. That's what we are going to discuss today. C1C2 dislocations have a varied etiology and can present in various manners. More commonly, they present either asymptomatic or with mechanical symptoms, particularly in adults, where before myelopathy sets in, the diagnosis can be made. Management of atlantoaxial dislocation is not a brainer anymore. There are various options with their own pros and cons. And transarticular screw with wiring has proven to be the one which gives immediate and absolute stability with the most strongest fixation with almost 100% fusion rates, classically described by Magrel et al. However, because of being technically demanding, it has not been used more provenly, and the reproducibility has been very low among inter-observers. The problems and complications may range from 15 to 23%, right from misplacement of screw to vertebral artery injury to graft side morbidity, and this has reduced its popularity in patients with C1C2 dislocation. We in 2012 came up with the concept of minimal invasive transarticular screw fixation with a standalone fixation without use of wires, using small incisions, giving the idea of retrograde trajectory, which is far more precise than the conventional Magrel's technique, and the results have been promising. We have always used allograft and has been published in peer-reviewed journals earlier. Some of the case scenarios proving the reliability of transarticular screw in polytrauma patients with odontoid screws, in patients with fracture lateral mass where C1C2 fixation segmentals cannot be done, and in patients with tuberculosis where regional osteoporosis and destruction of lateral mass may preclude the fixation in these scenarios. Advantages of minimal invasive transarticular screw fixation are pretty obvious and akin to minimal invasive benefits in lumbar spine surgery. It gives immediate absolute stability with absolutely low morbidity, and that has been proven wide and spread now. The question is, can it take the pediatric challenge? Is transarticular screw as efficacious in pediatric population also or not? The challenges in pediatric population are completely different because the presentation is delayed. Often these children present with myelopathy, and that's why wiring as an implant choice is not the primary choice. You may want to avoid anything intracanal. The etiology is different. More often than not, these kids have a syndromic etiology resulting into bony anomalies, making the bony stock to be improper for any kind of implant which can hold in the form of screws. And infections and inflammatory arthritis also can lead to erosions of the bone, further complicating the matter of implant choice available at hand. The biomechanics of implants available is limited. The options of implant available is limited. And the problem is once the implant fails, the salvage modalities are not defined at all. The problem gets further compounded because wires in terms of are not to be used in myelopathy patients. They can also get loosened over a period of time. Use of graft has always led to problems. And unplanned OC1 fusions, because it requires exposure of occipital upper arch of C1, can lead to unplanned OC1 and C2C2 fusions in kids in particular is a known problem in almost 25% of patients. This is one case example which highlights everything that we just discussed, that a poor bone stock in a patient with hypoplastic C1 with absent arch where wiring cannot be done, C1, C2 screws cannot be done, and OC fusion is too morbid. And then this is one case scenario where it highlights how challenging it is to manage these patients with pediatric C1C2 dislocations. So the question is, on one hand, wiring is not possible. On the other hand, OC fusion is something that is not possible. C1C2 fixations have a poor purchase. Implant choice is limited. Can transarticular screw be really relied upon? Is it dependable? And if yes, is it feasible to do it in pediatric population with a poor bone mass, narrow pars, vertebral arteries are so thick out there? So is it possible and feasible? The answer to this came from the first study in 2012 by Douglas L., where he said that 91% of pediatric patients are suitable to have a C1C2 transarticular screw. And this was the first time a landmark study that came from Douglas et al. We in our study studied anthropometrically that 91% of kids would be able to achieve the minimum pars diameter of the adult size by the time they are 8 years of age. And this was highlighted in our paper published in European Spine Journal. So now it is well established that transarticular screw is not only a gap filler but also the gold standard in pediatric C1C2 reducible dislocations. The only thing you have to now pay attention upon is pre-operative planning and the meticulous surgical technique, which any which ways you have to pay upon because the margin of error is very narrow. Pre-operative planning cannot be really overemphasized, but in these cases where all these 6 principles of planning have to be kept in mind while you're planning a pediatric transarticular screw. We'll go through them one by one, where indication, reducibility, feasibility, inventory, the implant choice, and of course the trajectory has to be planned before you really plan in surgery in these patients. And this is something that everybody must pay true attention to. So let's see them one by one. The indications do not change, and so are the contraindications. The only indication of a transarticular screw is a reducible AAD in a patient with suitable bony anatomy, and this is something that has to be ensured before surgery. Irreducible AADs, which are truly irreducible, and when I say truly irreducible, only the ones which have a bony block or a malunion happening at the orientoid side are the ones which are not amenable to transarticular screw. We consider that every AAD is reducible, particularly in kids population. When I say that all the AADs in kids are reducible, what I mean to say is that on something that may seem to be irreducible one on a flexion extension X-ray may not be a genuine irreducible one, because most of these will reduce the moment you give them general anesthesia and they go under are relaxed enough. Sometimes you may want to use maneuvers like pushing the C2 with a transoral technique, or you may want to push the C2 from behind on the prone position, really requiring the maneuvers like C1 wire to pull the C1 back, or joint distraction. Some case examples to show you, like in a patient with torticollis which seemed to be irreducible, was reduced by preoperative Gardner traction in these kids. Reduction by transoral thumb method should always be tried in all irreducible ones by transoral technique, and most of them will reduce. We have not faced any single case where it is irreducible unless there is a bony block present there. Another case scenario where intraoperative distraction use of pukas can help you reduce even the most toughest and the most irreducible seemingly ones, and they get completely reduced by use of all these maneuvers. So all of them are reducible unless there is a bony block present, which can again be caught upon preoperatively on your CT scans and MRIs. Now, once you've seen a reducible C1C dislocation, you have to ensure that the pars diameter is minimum 3 millimeters to hold upon the implant. Why 3 millimeters? Because the current implants available are in the range of 3 to 3.5 millimeters or 4.1 millimeters. And that's why to hold the currently available implants, maybe in future if we develop more implants, but currently I would say transarticular screw is feasible with the implants available only when the minimal pars diameter is more than 3 millimeters. And this has been highlighted in both our studies of anthropometric evaluation and surgical feasibility that has been published early in peer-reviewed journals. It also says that 91% of kids will have more than 3 millimeters by the time they are 8 years of age, and that is why you should not be worried whether they will be holding implant or not, and it is very well proven now. There are a wide variety of implants available. We have got our implant design where a fully cannulated Herbert screw kind of situation with a varying thread and varying pitch is available in market now. It is with various companies available, and this is something that is available and should be kept handy while planning these surgeries. A conventional Herbert screw also comes very handy, as has been a choice in some of our cases. Some case examples where a pars of 3 millimeter in a rotatory subluxation where we did a Herbert screw of 2.7 millimeters. And then this is something that we may pay attention to. Keep implants ready before you wash in for surgery. Now, this is one step that you all may want to plan pre-operatively. Like conventional Magra's technique mentions that there is a fixed entry point which is 2 millimeters above the joint line and medial to the joint line. However, in our case, we keep that entry point is tailor-made, and the only thing that is fixed is exit point, where your tip of the screw has to come in either zone 1 and zone 2, making sure that you miss the vertebral artery by a broad margin. And once your exit point is fixed, you have exposed the whole of pars, seen dorsal surface of it, seen the most medial surface of it. That gives you the trajectory, and that's why with a fixed exit point, retrograde trajectory on the pars that is visible, the most dorsal and most medial surface, wherever this line joins and falls on the lamina becomes your entry point, which is never fixed. This is slightly different from the conventional Magral technique. And this is something that must be paid attention to, that the exit point is fixed, your trajectory is retrograde, and wherever it falls on lamina becomes your entry point. And that's what we have been following so far, giving us wonderful results with no misplacement. Once you have planned it, then the surgical execution is as simple as any other case scenario. Do not expose the superior arch of C1 to avoid any inadvertent OC fusion. Do not expose the lower border of C2-3 joint, and always preserve the capsule of C2-3. Try to expose the whole of pars and the isthmus, the most dorsal and the most medial surface of the pars should be visualized right in front of your eyes, because that's where your guide wire will go. And then you can plan your retrograde trajectory. This is something that you may pay attention to, that your retrograde trajectory, wherever it falls on the lamina, becomes your entry point. And then it's all about C-arm guided guide wire passing, and you can easily run through your guide wires falling in the trajectory that you have already planned. Even in the narrowest pars diameter of less than 3 millimeters, you can easily get a guide wire in, and then cannulated drill bits and cannulated screws can then pass in, and you'll be able to get your nice hold in the screws. We always use allograft that is available in bone banks with us. Our joint replacement colleagues give a good hands-on into it, and we have been really satisfied with it without the use of supplemental wiring in any of these case scenarios. And this has given us really satisfying results so far. Some case examples where JRA and rheumatoid inflammatory arthropathy is managed in pediatric population with wonderfully placed transarticular screws giving an exit point in zone 1 and zone 2. Herbert screw in even a narrow pars of 2.9 millimeters come really handy. We already have 2.7 mm Herbert screws available in the industry. Torticollis, patients presenting with torticollis due to nodentoid malunion, already established malunion, you can again with the help of thumb push technique reduce it completely, and you don't have to really do intraoperative maneuvers to reduce them. Sometimes you may need intraoperative maneuvers, like in this particular case scenario, we not only had to do a transoral push, but also a push from behind prone, and it was completely reducible, even in a patient where there was established malunion happening there. Rotatory subluxations, again, intraoperative distraction can help you. Smaller incisions will help you get in there, and precise retrograde trajectory gives you a tailor-make entry point there. Even in syndromic patients, it is really possible to do. Tuberculosis, where one lateral mass is destroyed, you can use it. With these kind of learning experiences we have had, we have expanded our wings, and we now are able to do the same transarticular. So even in patients with dysplastic anatomy, even in patients with high riding vertebral artery, which is not the usual place where we recommend it. However, with the help of navigation, even in patients with dysplastic anatomy and high riding vertebral artery, it is surely possible. Like in this patient with os orontorium, we are able to do it. And in a patient with high riding vertebral artery, again os orontorium, we were able to get a good fixation with the help of navigation guided transarticular screw. C2 has now become more reliable. We have been using it as the lowest most anchor in even patient with basal invagination where OC fusion is done, and even in syndromic AEDs with BI, this is the most reliable and absolute measure of getting stability. Results have been extremely encouraging. We have not had a single case of non-union, and bony fusion can be seen not only on X-rays but on CT scan. A thick layer of bone can be seen to be forming. Of course, transarticular screw is demanding. Vertebral artery injury in 2 of our cases have happened in out of a series of 400 cases. However, none have happened in pediatric population and none in last 250 plus cases so far. And this is purely because of the planning that we have been emphasizing more and more in these days. Yes, there are limitations which we have highlighted in our paper on learning curve of MIS C1, C2 fixation. But remember that by the time you are done your 30 cases, you are already saturated your learning, and it's very gradual after that. So this is something that you may want to practice upon in cadaveric courses, in sawbone workshops, and this something will come really handy. So to summarize, pediatric transarticular screw is the new gold standard, and it is surely possible and feasible, efficacious, reproducible technique provided your minimum pars diameter is more than 3 millimeters and you pay meticulous attention to preoperative planning. Thank you so much.
So that was a lovely presentation, Vishal. I open the presentation to the House. Any questions? First, I would like to ask our Argentinian colleagues to have a go if there is any question or anything that you would like to clear on this.
Yes. Can I do a question?
Yes, sir, please.
Well, very interesting presentation. Thank you. I have a question about the vascular situation. I want to know do you do any vascular image usually or frequently in children to do this technique, or just we don't need it to do?
So very, very interesting question, Dr. Pablo. Thank you for bringing up this question there. So vascular CT angiograms, initially for our first 50 cases, we regularly used to do it. But now we avoid doing a regular CT angiogram to study the vascular anatomy unless and until there is a bony anomaly. There are multiple papers which suggest that the chances of having a vertebral artery which is anomalous in nature, they are usually associated with one or other kind of bony anomaly. So in kids where there is no bony anomaly, we would routinely not do a CT angiogram now. However, having said that, for all beginners, for initial first 50 cases, I would recommend that everybody should do a CT angiogram to check and find out if there is a high riding vertebral artery or an anomalous vertebral artery in the C1, C2 space where maximum dissection happens. Again, as I mentioned, the high riding vertebral artery, just to have a diagnosis of high riding vertebral artery where transarticular screw can become a challenge, you necessarily don't need a CT angiogram. You can actually study the minimum pars diameter And if it is more than 3 millimeters, I think it is extremely safe to do, even when the diagnosis of high riding vertebral artery has been made by a radiologist.
Gautam, may I?
Yes, please, Marcelo.
The presentation was outstanding. I mean, you went over almost every detail. There's not too much to answer because it was really to ask because it was really very clear. But my question to you is, what happens if your measurement shows you that you have less than 3 millimeters? Which is your usual alternative option?
Very interesting. Again, Marcelo, as if the minimum pars diameter preoperatively is less than 2.7 millimeters on both sides, then I would preclude using a transarticular and rather depend on only C1, C2 wiring. Because the moment pars diameter is less than 2.7 millimeter, there is no other implant available currently in the industry. Now, again, it brings me to an interesting part of this, that 80% plus kids more than 3 years of age have their pars diameter, which is more than 2.8 millimeters. We recently have published a study on anthropometric analysis of minimum pars diameter in kids more than 3 years of age. So every kid, I would say 80+% of kids who are 3 years and above, their pars diameter is already 3 millimeters and above. And so the chances of you getting a pars diameter less than 2.7 millimeter in a child of 3 years and elder one is less than 15%. So I would say that it's very rare to see a pars diameter of less than 2.7 millimeters unless it's a grossly syndromic craniovertebral junction, where again you would rather rely on either C1, C2 wiring if it is possible, or you would do a OC fusion. Now the other fallacy to this is the moment you see a pars diameter of less than 2.7 millimeter, where there is already a syndromic craniovertebral junction, the chances that you will have a complete C1 arch to hold on wires is also extremely rare. And that's why the only choice that will be left behind to you is OC.
Right. Any other questions before we move on? No?
Yes.
Okay, thank you. Yeah, Dr. Bernasconi, please go ahead.
No, it's just a question about the cannulated screws. Do you use every time a cannulated screw, Vishal?
Yes, Dr. Pablo, it's again very interesting. Unless until you pass in your guide wire, it will be extremely impossible to drill it freehand because you have no second chance to drill in there. And that is why to not use a cannulated screw becomes extremely difficult, because otherwise getting your guide wire in, and in these soft bones, if you don't run your cannulated screw on the guide wire, the chances that a solid screw may pass into a different zone completely is very high. And that's why I always use a cannulated screw which can pass on a guide wire.
Thank you very much, Vishal.
Thank you.
And that was a lovely presentation. I think fantastic, as Marcelo said. Can I request Marcelo to invite the next speaker, please?
Yes. So please, I would invite Juan Emerich. He's a neurosurgeon from the city of La Plata. He's a very well-known here in our spine community. Juan, are you ready to join your screen with us?
Yes. Yes. Hi, hello, good morning, good afternoon, good evening. My name is Juan Emerich. I am a neurosurgeon from Argentina. It's a huge honor for me to be here. Thank you so much to the scientific committee for this beautiful invitation. I learn a lot from the Indian surgeons every time I meet them in an international meeting. So again, this is a huge privilege to be in front of you. Thank you so much for this kind invitation. My lecture will be a surgical approach for cervical spondylotic myelopathy with kyphosis. These are my disclosure and my academic affiliations. I don't have any conflict of interest for this presentation. We have three main objectives for today's presentation that are mainly identify which are the goal when we treat this patient, describe the different scenarios in which patients with kyphosis came to our practice, and finally which is the best surgical approach for each case and how to perform a successful surgery. If we made a review of the actual papers, we are going to identify that there are not a clear rule of how we deal with these patients. There are authors who say that we can go for an anterior approach alone, others who say that we need to go for a posterior approach alone, and we have authors as well that say we need to go in a 360 approach with an anterior and posterior combined in the same surgery. And this is extremely important because in some way all of them are absolutely right, because we need to understand which will be the objectives of our surgery. When we treat this patient with a surgical treatment, we try to achieve the compression of the spinal cord, to have the spinal cord centered inside the spinal canal, and of course leaving a stable spine. And as already says, we can reach these objectives with different approaches. There is not only right way to achieve this. So just a few examples of patients who came to our practice. And as you can see, we treat this patient with the anterior approach alone, posterior approach alone. Just as example again, laminectomy plus fusion, laminoplasty. So there is not one rule that say all these patients, even with patients with kyphosis, need to be treated for anterior or posterior approach alone. How we can select the right surgical treatment for each patient? There are three issues that we need to keep in our mind when we decide how to treat these patients, and these are the etiology of the cervical myelopathy, the level of compressions, and the radiological alignment. This is absolutely different when we treat a kyphosis or a cervical deformity that it's from a degenerative disease like in the cervical myelopathy usually, or we are treating a patient who came to our practice with a deformity after a tumor, a trauma, an infection, or even worse if it's after a previous surgery. And why this is so important? Because the papers who show a clear link between the outcome and the level of correction that we can achieve in the surgery when we treat these patients are mainly in patients who have a trauma, a tumor, infections, or iatrogenic deformity, not in the patients who have degenerative disease. And this makes a lot of sense because the patients who have trauma or infections used to have, let's say, a normal alignment in their spine, so they have an acute disease who change that reality. It's totally different in patients who have degenerative disease. Another important issue is to understand if we are dealing with a single level compression or a multi-level compression, and probably even more important if we have a patient with a normal canal or a narrow canal. If we are dealing with a patient with a multi-level compression and a narrow canal, probably we need to think in a more comprehensive treatment because that patient need a multi-level treatment. And it's different if we are dealing with a normal canal and a single level compression, that probably we only need to make our focus in that level and forget about the rest of the spine. When we think in the radiological alignment, at the beginning it looks very easy. We have 4 different possibilities. There are lordosis and straight spine, sigmoid spine or kyphosis. We can see a few examples. However, we are learning that the cervical alignment it's not isolated from the rest of the spine. Many papers are showing to us the importance of the T1 slope, and we know how the sagittal balance have an impact in the cervical spine. And probably more important when we talk about radiological alignment, it's to keep in mind that it's not the same, the alignment, in the X-ray or the MRI. And I believe everybody agree that we need to take these measures in X-ray. However, when we decide how to treat these patients, we always look the MRI to select if we go to an anterior approach or a posterior approach. For all that reasons, we decide 25 years ago in the 1990s, change the concept of release and correction of the axis to try to achieve that we call spinal cord aligned. With that concept in mind, we look for the spinal cord above and below the compression and identify a place where the spinal cord is centered inside the canal. Then we draw a line that joins both points, and we call that line posterior spinous line. We published this in 2006, and since then we are using to decide when we go for an anterior approach or when we go to a posterior approach. So we can have two possible scenarios. One that we call negative, it's when the spinal cord is behind that line, or positive, that it's when the spinal cord is in front of that line. And we use this concept to decide, like I told you, how we're going to treat this patient. So for us, when this line is negative and we have a multi-level or a single-level compression, will be an indication to go to an anterior approach. In these cases, we decide to perform discectomy or corporectomy of one or more levels. Let me show you a couple of examples. This patient with a single level compression in a normal canal, we decide to perform a corporectomy and fusion with a very good outcome with a follow-up of 5 years. Especially in the single level compression, there is not only one solution. You can choose from the different techniques, and mostly of them have a wonderful outcome. Here, different techniques, very old patients, treating some of them 20 years ago with a really good follow-up and an excellent outcome. And when we go with the posterior approach, when this line is positive, and especially when we have multi-level compressions. In that cases, we have the possibility to choose a laminectomy or laminoplasty. Both of them could include some kind of fusion. And let me show you a couple of examples of patients who have strides or with a small kyphosis spine to show you how we can use the posterior approach to treat these patients. This patient, 75 years old, again, we mark this line, and in our concept allowed to go by the posterior approach. Of course, he have a fixed spine, so we decide to perform a laminectomy without fusion. Here, the pre and post with a good outcome and 6 years follow-up. Another case, this patient could be treated by an anterior approach with any doubt, but we decide to go by a posterior approach because he have a multi-level compression. In this case, we chose a laminectomy plus a fusion with a pre and post with a 7 years follow-up, again with a really good outcome. And finally, a very tricky case, a male, 72 years old, with instability for walking, with rapid progression that was really worsening in the last 7 days, difficulty for fine movements in both hands, and loss of strength in 4 limbs. You can see here the sagittal and axial MRI. This patient could be treated with any doubt by an anterior approach, but we decide that we can fix this pathology with a posterior approach, preserving some mobility that the patient have at that time, and especially to treat the levels before and below the most worst part of the compression. So we decide to treat by a laminoplasty. So we perform in this patient an extend laminoplasty from C2 to T2. Of course, this is not the usual laminoplasty. And as you can see in this 1 year follow-up MRI, we achieve a very good compression of all the levels. Here you have a pre and post with 1 year follow-up. These X-ray are 2 years after the surgery, and you can see that the patient keeps some mobility of the spine. Here are the pre and post, and again, with any doubt, most of you could treat this patient with the anterior approach and with a very good outcome, but we believe that there is place for the posterior approach in the cervical myelopathy with kyphosis if we select the right patients and we use the right treatment. As conclusion, we can say that to select the approach and the correct techniques, we need to keep in our mind the stability, if it affects one or several levels, and especially, at least in our concept, is the position of the spinal cord inside the canal. There will be patients in whom the indication of anterior or posterior approach seems very clear, and I believe mostly of the surgeons don't have any doubt. But will be many cases, it will depend on the preference and experience of the surgical team.
Thank you very much, Dr. Emerich. That was a wonderful presentation. I think a very novel and a new concept. Have you published this at all?
Yes, thank you. We published in 2006. My boss and my professor is Nestor Fiore, a really well-known surgeon here. And we spread probably this knowledge in Latin America, but we are a little bit lazy, and perhaps we don't spread too much outside Latin America.
Whilst the others warm up to ask you questions, let me put the first question to you. Does the line only dictate whether to go anterior or posterior, or does it dictate the length of your decompression also?
Yes, amazing. Thank you for that. The good idea behind this concept is that not only select the approach, but give you, as you well says, the level of the compression we are going to search. Some of the critics could say that we are moving this line one level below or one level after that. But the idea is that we can project, and we have more than 300 patients following this rule, and we can project in a very good way the final result, the outcome. So it's not only compared with the key line that is a similar concept. It's not only compared when we go to an anterior or posterior, but as well we can decide the level of the decompression with a good, follow-up.
Before I ask Dr. Srivastava to ask a question, there is a question from the audience, and that is, can you please repeat the marking points for the line?
Yes. So we identify the level of compressions, and we look for one place when the spinal cord is in the ideal position. That means center in the canal and with CSF in front and behind. So that will be at least our ideal points, one in upper and one below the level of compression. And then we draw a line that go in the union of the lamina and the spinal process, and we can identify from that level if our decompression, because that is the idea behind the concept, will be enough to leave the spinal cord center in the canal and with a good evolution.
Right. Dr. Srivastava?
Yeah. So, very good paper and, paper you read just now, Mr. Juan. I have two questions simultaneously. One is that if you have a dynamic instability where you feel that this laminoplasty is not going to help, do you change the plan? That is one. And second, do you have increased incidence of C5C with a long laminectomy?
Yes, thank you. Both are really nice questions. The first idea is, of course, very clear. We use laminoplasty only when we don't have instabilities. If we have instability, we perform laminectomy plus fusion, or even in some cases, we perform a huge laminoplasty not huge. I mean, from C3 to C7, and perhaps if there is a very focused instability, we only fix that level. Could see, C6, C7 sometimes, but depends patient by patient. And the second question was about C5 fallacy. I see plenty of papers who show this C5 fallacy. However, we have plenty of complications. We are very far to be perfect, but we don't have too much C5 fallacies. And I believe that is something related with the technique. We try to be, very, very clear that the compression is good. We sometimes add a foraminotomy. But again, this don't mean that we don't have complications. We have plenty of complications. But at least in our series, to be honest, we have only one patient in more than 300 patients with a C5 that was only 2 weeks, and then he had a full recovery.
Questions from Dr. Pablo? Dr. Bernasconi?
Yes, hello. Hello, Juan, a pleasure. I have a question about, it's a technical question about the C3, because I saw especially in the last patient that you showed, that you are doing a laminoplasty at C2 also and C3 level. There is like a new concept that doesn't work. What is your opinion?
Yeah, usually the traditional laminoplasty we perform, it's from C3 to C6. That is the usual laminoplasty, because I understand your idea. When we perform a laminoplasty in C7 or in C2, it's always that huge doubt about the muscles and how it's gonna go this patient to a C4 later. And I bring these cases, I know Marcelo Gruenberg knows this case very well, because always it's extremely controversial. You say, when I don't see too much cases that we go to laminoplasty to T2. We include C2, not so many times, but we do plenty in C2, 20, 25 cases, but not too low than T2. But again, the concept is that we can use in very select patients, we can include C2 and C7, because if we have in our mind that we can include C2, we saw plenty of patients that have a good laminectomy from C3 to C6 to C7, but remain with a compression in C2, and that is really, really bad. If you're not so happy to perform a laminoplasty in C2, you can perform a laminotomy in C2, a partial laminotomy, trying to protect the muscles and just perform in the half below the level of the muscles, and could be effective. But I understand that this is a very controversial case, and that is the idea what I bring here.
Last question from Dr. Marcelo before we actually move on to the next talk.
Thanks, Gautam. I'm aware of the work that Juan and his colleagues from La Plata are doing. I mean, the work is outstanding. They are so expertise in this that they move the indication to almost everybody. And if I have to have a laminoplasty for myself, I will travel to La Plata, not with Juan because I cannot afford his fee, but to one of his colleagues. My question will be, with this disclosure, my question will be, when you draw the line that we draw it and we learn it from them, we are aware that we do that with the MRI. But then the patient have another posture that is more related to the standing or sitting X-ray. And the MRI reflects the position in which the technician put the patient for doing the procedure. So I wonder if they have any special measure to know that the MRI reflects what then is going to happen when the patient is sitting or standing.
Yes, that is an excellent question, Marcelo, as usual. And you can came to the Plata, I go to do a special discount for you. Don't worry about my fees. Take it easy. So yes, especially we perform all our MRIs when we have a laminoplasty with a particular doctor who he pay extra attention how he position that patients. It's not easy because it is not 100% of the cases. But again, I believe the important it's if we say that the patient is in kyphosis or in lordosis, we learn from the beginning that we need to follow the X-ray. So here in the MRI, more that if we are looking that the patient is in kyphosis or lordosis, we are looking the alignment of the spinal cord inside the spinal canal. And at least in our concept, this is not so affected for the position of the patients. Because again, theoretically, when we open that spinous process, we're going to have enough space to the spinal cord could be, free inside the spinal canal. But I fully agree with you. The MRI depends a lot of the position of the patient inside the equipment. That is absolutely true.
Thank you very much.
You're welcome. You are on mute, Gotham. We can see you, you're moving your lips, but we can listen to you. You are still mute.
Hello.
Yes, we got it. We got it.
So, yes, Marcelo, we are running about 7 to 8 minutes behind time and we need to buck up. I'm going to invite one of the dynamic spine surgeons from a city in Western India called Ahmedabad. And he is one of the pioneers of minimally invasive spine surgery.
Sir, you've gone mute again. Sir, you've gone mute again.
Hello, can you hear me?
Yeah.
Yeah, can I invite Dr. Amit Jhala's presentation, please?
First of all, I would like to thank Association of Spine Surgeons of India for giving me this opportunity to present. And we all know that direct decompression is the traditional conventional procedure with a transforaminal lumbar interbody fusion for degenerative spondylolisthesis. And you can get a very good result clinically as well as around 95% of fusion rate in this TLIF procedure. What I'm going to present is what is the role of indirect decompression in degenerative spondylolisthesis. Now, this is a patient of degenerative spondylolisthesis with an actual MRI showing moderate grade of lumbar canal stenosis. And the question is, does this patient require a direct decompression? What we did was an indirect decompression, and what we could achieve by just putting the cage anteriorly is reversal of the disc bulge, stretching of the ligamentum flavum, distraction of the facet joint, and you can see there is a whole lamina which is intact, and reconstruction of the whole spinal canal with a good increase in the cross-sectional area. And in sagittal image, you can get a good disc height, you can get a good reduction and a good lordosis with opening up of the spinal canal. So if you see, this is a more of a physiological approach. And if you see the pathogenesis of degenerative spondylolisthesis, there is a loss of disc height which gives rise to ligamentum flavum buckling. There is ligamentum flavum hypertrophy because of the hypermobility. And because of the degeneration of the facet joints, what you can get is a static compression because of the loss of spinal alignment. And all these things can be reversed by just inserting a large spacer which goes from anteriorly, which goes from one end plate to the other end plate. And what you can get is stabilization of the spine, jacking up of the disc space, reversal of the buckling of the ligament and PLL by ligamentotaxis with alignment of the spine and a good indirect decompression. Over and above this, there is a large area of the fusion which you can get because you are going anteriorly and good amount of disc space clearance that you can do. And everything can be achieved either by OLIF or XLIF, but my personal choice is an OLIF procedure. And you can see in this case that there is a loss of disc height, but you can see how much amount of distraction that you can get. And that's the power of checking of the disc space. You can get a good realignment of the spine by inserting this large size cage. So there is a big principal change which has occurred from PLIF, which did a laminectomy and bilateral grafting, which had increased neural retraction and increased chance of deficit, to a TLIF procedure, which is a gold standard as on today, where it's a more destructive approach, according to me, where you do a lot of facetectomy, you enter the spinal canal with all the problems of neural retraction, neural injuries, and chances of neural injuries. Compared to that, OLIF, there is no morbidity of the posterior approach because you are not going through the paraspinal muscles, so you are not entering the spinal canal, and all its eventualities of neural retraction and epidural bleeding that can be avoided. There is no peridural fibrosis, and because you are going more anteriorly, you have a better disc clearance, you have a better biomechanical position for the cage, and you get a good lordosis. So there's a principal change from TLIF to OLIF, and the main important part is in degenerative recesses. These are the different actual images of the patients having degenerative spondylolisthesis. And the question is, how much is the indirect decompression? What is the limit of the indirect decompression? Whether it is limited to only instability and foraminal stenosis, or you can stop at a moderate canal stenosis level, or even you can go up to the severe canal stenosis as is shown here. So this is a case of Shiza's grade 1, a fairly simple case where there's just a foraminal stenosis, and by putting and jacking up the disc space, you can increase the foraminal diameter and stabilize the spine, and you can get a good result. But this case, there is not only a foraminal stenosis, but there is a ligamentum flavum hypertrophy and a central canal stenosis also. And by indirect decompression, you can just achieve a good canal clearance even in Shiza's grade 2 with a moderate type of stenosis, as is shown in this case also. So the question is, how much indirect decompression? And so what we have done is we have selected few articles and tried to find out what is the increase in the spinal canal area. And if you see that the first publication was from Oliveira in 2010, and there are so many articles in 2020, but these are the select few. And what I've done is try to find out what is the difference between the initial learning phase of indirect decompression and what is going on as on today. And you can see that initial case in initial series, what the spinal canal area that you could achieve was around 30 to 33%. But in recent articles, you can increase the spinal canal area by 140 to 172%. And no patients, fortunately, right from the first article, except the 2 patients in Oliveira, which was a standalone case, cages, none of them required a direct decompression, and all of these patients clinically improved. So in 2017, Roger Hartwell group, they published this potential and limitations of indirect decompression. What they concluded that this is a very good technique for decompression of the foraminal stenosis, but the evidence on decompression of the central canal was lacking, according to them, in 2017. But there are so many articles which have come after this article. And this is one of our publications, and this is what we are following right from 2016. And this was a publication of 60 segments. You could get around spinal canal area improvement in 42.7% and a good clinical result in 97% with no patient requiring a direct canal stenosis, direct decompression. But what we did was a subgroup analysis in the same series, and we could find that the spinal canal improvement was much more in severe stenosis. And so we decided and looked back to our cases with more of Shiza's grade 3 and 4. So this is one of the case with Shiza's grade 3. And you can see the amount of decompression that you can get, or spinal canal area improvement you can get, is much more in Shiza's grade 3 and Shiza's grade 4. This is another patient, Shiza's grade 4 or a D. And you can see how much amount of decompression or spinal canal area improvement you can get. You can get a good canal reconstruction in sagittal images also. Another patient, a severe degree of or grade D type of Shiza's, and you can see how much amount of decompression that you can get or improvement in spinal canal area you can get post-operatively. It's a quite huge amount of improvement that you can have. Another patient with similar kind of a result, you can get a good amount of spinal canal area improvement in Shiza's grade D type of cases. And this is what we presented in Assicon 2020 with 105 segments which were evaluated between 2016 and 2020. And we did a subgroup analysis of 44 segments which belong to Shiza's grade C and D. And we could get indirect decompression which was effective in these cases also, with a good fusion rate of around 93%, and no patient required a direct decompression. And we evaluated the foraminal height, disc height, but the most important is the improvement in the spinal canal area, which was much more, which was 42% in our initial series to 75% in these cases. That means you can get a good amount of canal clearance in higher grades of Shiza's lumbar canal stenosis. The similar results are produced in other the studies also. This is a a very good study. They studied just scissors grade C and D with 1 year follow-up study, immediate immediate MRI and 1 year follow-up study MRI. And no patient required a revision surgery in that study. And you can see the overall expansion was around 274% with 88% fusion rate. And you can see that in this, one of the examples that they've published, you can get around 580% of the expansion. So it is effective option even in severe lumbar canal stenosis. That was their conclusion. In one more study, which they have followed up for about 2 years, and they have said that you can get a progressive increase in decompression because there is remodeling of the spinal canal. There's thinning of the ligamentum flavum as your follow-up increases. And you can see that this patient, which was scissors grade C, which improved to actually scissors grade A in 2 years follow-up. And there's a progressive increase in spinal canal area, which increases in their series from 140% initially to 189% at 2 years follow-up. And therefore, the indirect decompression produces immediate positive results, but that continue to improve over the time. And the cross-sectional area of the thecal sac actually doubled after 2 years. And the similar result in the long term has been already published. And this is a 10-year MRI study of an ALIF with indirect decompression. And this is their case that they showed that in 10 years, there is actually hypertrophy of the ligamentum flavum because of the fusion. And their conclusion was that stability of the spine may have induced the change of lumbar ligamentum flavum, and there is remodeling of the spinal canal. So definitely, as you follow up more and more, there is remodeling of the canal, and you can get a better and better decompression. Now, there are certain factors which are very important for successful indirect decompression, and you know that the indirect decompression basically depends on the jacking up of the disc space, and for jacking up of the disc space, you require a good bone quality. So if you don't have a good bone quality or you have an osteoporosis, this jacking up may not occur, and you may have actually damage to the end plates while jacking up. So it's not a good candidate. Osteoporosis are not a good candidate for this type of decompression. We all know that we have a good data for moderate central canal stenosis also. But in severe, that means scissors grade D, the data is still lacking. And it's very important that you have a very good footprint of the cage, which goes from end to end. If it does not go from end to end, again, you cannot jack up, and you may actually, there is a cage subsidence, and you can get a recurrence of the symptoms. So these are very important factors to consider if you want to go for an indirect decompression. So overall, the indirect decompression significantly increases the overall spinal canal area by stretching the ligamentum flavum. Though some amount of compression is visible in post-op MRI, gradually there is remodeling of the canal by hypertrophy of the ligamentum flavum in long term, maintaining the decompression effect or increasing the decompression effect. And direct decompression is not the only pathology in unstable lumbar spine. Actually, it is dynamism which plays much more important, and stabilization itself gives a clinical result initially. And objectivity actually needs to be assessed regarding the role of indirect decompression and the amount of compression. Thank you very much.
Thank you, Amit. That was a lovely presentation. I will invite 2 questions from my Argentinian colleagues today. Dr. Bernasconi, you have a question for Dr. Jhala?
Yes. Just I have a question, of course, about the indirect decompression, and also to decide which is the best method to do. And some authors, they mention a lot the monoligament buckling to decide which kind of method can I use. For example, an X-leaf or an O-leaf. I want to know his recommendation, please.
Basically, thank you for the question. My main personal choice is to do an O-leaf because of multiple reasons. One is that it is much more safer compared to the X-leaf, because you are going anterior to the psoas, and the chances of getting the thigh pain and the lumbar plexus injury is much, much less. The second is that your limitation of X-leaf at L4-5 is much more because of the prevention of the high iliac crest. and that may not allow you to go for X-lift procedure. But as far as the decompression is concerned, I don't think there is any difference between the X-lift or an O-lift procedure. So, but that's a personal choice. Plus, there is no need for a neuromonitoring if you do an O-lift procedure. So these are the advantages why my personal choice is an O-lift rather than an X-lift procedure.
Yes, any more questions? If not, then I would like to ask Dr. Marcelo to invite the next speaker, please. Thank you, Amit.
Thank you.
Thanks, Gautam. Thanks again. Well, the next speaker is our Spine Society president. He still have 2 more months as the president. Juan Pablo Bernasconi. He's going to talk us about a subject, a topic in which he has a good experience, multiple rod instrumentation for spinal deformity. Please, Juan Pablo.
But I already sent the presentation. Okay. Okay. Hello. Thank you very much to invite me to this fantastic meeting. It's really a great pleasure for me and also for the Argentinian Spinal Society. So thank you very much. So I'm going to talk about the multiple rods constructions, instrumentation in adult spinal deformity. The adult spinal deformity, everybody knows, is a very controversial chapter, with a very important complication rate, especially the late post-op complication rates, that they are very high, relate to the implants. The most common cases are hardware breakage or implant breakage, implant loosening, loose of the correction, non-union, and several causes, around 30 or 40%, especially at the lumbosacral junction transition, at the osteotomy place, at the vertebrectomy place. So it's a very complicated pathology to approach with a very important rates of complications. One thing is a fact today that we are operating older people than years ago. That's first because the life expectancy is very high today in most of the countries around the world. And if you see here the sentence in red, this is the number of patients operated between the period 2004 and 2015. It's around a double. It's a progressive growing of the patient or the older patient that we are operating. And this is a very interesting new concept. This is a concept that the scientific called super aging society, means that 20% of the population in one country have people with more than 65 years old. The point is that today there are 5 countries in this condition, this situation. In Europe, at the head are Italy and Spain, but in 2030 will be 34 countries. So the number of patients, the older patients, become larger than years ago. This is, for me, a very interesting graphic to understand what happens when we operate on the spine and we do a correction, an osteotomy, and vertebrectomy, etc., etc. Usually at the beginning of the surgery, we are leaving the hardware in the very stiffness situation to provide a very good stability. And at the same time, we are leaving the graft ready to grow. So at the end of the healing process, we can say healing process, that takes around 24 months, we will have a very good bone fusion and we don't need more the hardware. This is the classic spine cross rod that usually we can observe this in healthy people. But in the adult people, and especially in adult spine deformity, the situation is pretty different. because you can see here in the list in the left side, first is the patient older. Second is a patient with very poor bone quality. That's very important. And the cigarettes plays a very interesting role in the complications, sometimes with the diabetes, obesity, and became very more frequently the extrapyramidalism syndromes that are very common in this kind of pathology in older people. The other point is that, in my opinion, we are finding more complex deformities. And these complex deformities, not in all the cases, they are primary. In most of the cases, they are secondary to the multiple surgery, so became more complicated to treat it. In the second list, over this situation, usually we are doing a very aggressive technique, surgical technique in the adult spinal deformity, with a very, sometimes the degree, the rate, the correction rate is very high. The bone resection became very large in some cases, with pedicular osteotomy to 1 level, 2 levels, vertebrectomy, and in most of the cases we go to the fusion to the pelvic. So the scenario in this particular chapter, adult spinal deformity, is not very nice. It's a very risky scenario. So to obtain the crossroad spine variables necessarily can be pretty difficult. Why we use the multiple rod contraction? We try to use multiple rod contraction just like a mechanical way to try to improve the stiffness and the stability at the beginning of the surgery and during more time, with a main target to improve the fusion, to keep the correction, to avoid the complications that we can have, especially the late complications. The multiple rods contraction, you can use it, I use alone sometimes, and I use combined with any anterior supports, I mean, I lift, exit, etc., etc. Two articles that for me, they are very, very interesting is this article about Manish Gupta presented at the SRS in Montreal a couple of years ago, when he classified the different constructions with main roads, accessory road, and satellite roads. Very interesting. Here's a result. We can see here in the left side the difference result, the different consolidation rates using the different constructions. Another article that is very interesting is the article by Pedro Garcano and Claudio Lamartina that they did a finite element model using one construction that they call delta crossroad. Very interesting to reduce the stress and very interesting to reduce the torsional loads. The torsional loads are the principal factor that can produce implant loosening in the interface between the bone and the screw. So this is a very, very interesting paper, both of them, to read it. Let me to show you a couple of examples about the surgery that we are trying to do with multiple rod contraction. This is the patient young, 48 years old, operate 4 times. She began with a decompression alone, then decompression plus fusion, then infection, implant removal. So she developed this iatrogenic deformity. So we treat with the multiple rod contraction in terms to improve the fusion and the stability at the beginning of the surgery and during a period of time more than 1 year to maintain the correction and to improve the fusion. This is another patient. This is the female with the Parkinson disease. Operated 2 times, decompression alone and then decompression plus fusion. This is has situation with a rigid deformity in the sagittal plane, also with a fracture on the top of the instrumentation. So this is the procedure that we did associated with multiple Smith-Peterson osteotomies at the kyphosis level. And then you can see the classic construction that we are doing since 5 years, 6 years, using the two main roads. You can see here the graphic, the main roads attached to the pedicle screw, and then 2 accessory roads attached to the main road with a couple of dominoes. Usually we attach directly the accessory rod to the iliac screw with a very good result. It's a very easy construction to do. This is another patient. This is a male 5 times operator. Here start with decompression, the simple decompression, and then with the arthrodesis, then a PGK, then infection, then implant removal. And he developed this pathology as another kyphosis, pretty flexible in the sagittal plane. So we did the same, multiple Smith-Peterson osteotomies, and then the instrumentation using the same concepts, main rod, an accessory rod attached, in this case, particular case, with 2 dominoes, and attached directly to the pelvis. This is another classical rod breakage of the lumbosacral junction, very common. The gut result in the sagittal and in the coronal plane. Here, another example. This is the female with a classic PGK developed, like you see here, 6 months after surgery. The patient present with pain, of course, and neurologic compromise. So I did this second surgery using the just and simple contraction attached by dominoes. It was a mistake. So you can see here, after 1 year, rod breakage at the transition area first. And if you see more specific this part, the anterior aspect of the spine, I think everybody think here that needs a pretty support. So we did the first procedure, and I hope that will be the last, using the combination of method, the lateral approach to put 2 cage, 2 X-sleeves at this level, and then the classical contraction with multiple rods. So very interesting. Our experience with multiple rods in this kind of pathology, especially in revision surgery in older patients, are very, very good. This is another contraction that I show you the article by Pedro Berjano and Claudia Lamartina. This is the patient operated 2 times, and also she has a bariatric surgery for obesity. Let me to remember that the bariatric surgery and the spine surgery, for me, are enemies. It's a very dangerous situation, operate a patient after a bariatric surgery. She developed an additional syndromes that we treat using a combination, a couple of X-sleeves, and then the classic cross, the delta rod technique of contraction. Very interesting in the delta rod contraction in patients with osteopenia, because she has a very good impact in the torsional loads. And everybody knows here that the torsional loads are a very important factor to reduce the implant loosen. So it's an attractive option in patients with osteopenia, and in cases that we don't need to go to the sacrum or to the pelvic. So the summary, I think that the most important situation or the most important scenario that to try to obtain with the spine surgery is this, the crossroads spine, because we are compulsory to do these crossroads variables between the hardware and the graft. This is very difficult. There's a pretty difference in healthy people than in adult spinal deformity. So the multiple rod contraction alone or combined with any anterior supports is a really very good mechanical option to try to improve our results in this complex pathology. So, thank you very much for the invitation again. It was really a pleasure. I hope that one day I will see you in my country, Argentina, so you are welcome. Thank you very much.
Thank you, Dr. Bernasconi. We look forward. We've heard so much about Buenos Aires and how lively a city it is, and we would love to be there at some point in time. The fantastic talk. I think this introduction to a multi-rod concept is very different for us because we have used them for crossing a pedicle subtraction osteotomy, but I saw that you use it for a lot of other cases too. Any questions from our panelists over here on the platform for Dr. Bernasconi? Yes, Dr. Srivastav?
Yeah, so very good concept. I just wanted to know, with the supplementary rod which you go to pelvis, do you make any effort to correct the pelvic tilt, or it is just a supplementary rod?
No. Can I use? Can I do the both techniques? Can I try to correct the pelvis retroversion and to try to maintain, and then to put the supplemental rod? It's the same. The use of the supplemental rod at the lumbosacral junction is because the cellular arthrosis rate is very important. So it's a good option.
Dr. Bernasconi, there's a question that when you put in 4 rods, your muscle closure over that is a little difficult. You're creating greater dead space. How do you circumvent that?
No, I haven't. The muscle covered, you tell?
No, how do you, when you put in 4 rods, it creates a lot of dead space. So how do you tackle the dead space which is there? Is there a problem?
No, I don't understand, sorry. Dark space? I don't understand.
Dead space. Dead space means a lot of leftover space because tissue does not close properly over it.
No, but I haven't any problem.
You haven't had any problem. That's great. Thank you very much, sir. Any other questions before we move on to the next presentation? Sushil, can you play my presentation? I am the next speaker.
Yes, sir. Do you want me to present you, Gautam?
47-year-old lady presented to us with back pain for 6 months, increasing pain since the last 2 weeks, and a progressive paraparesis so that she was unable to walk since the last 3 days. Examination revealed a spastic paraparesis with power being grade 3/5 in both the lower limbs. X-rays showed a D4 pathological fracture, and the MRI confirmed the presence of a D4 fracture with retropulsion of bone and extension of soft tissue into the epidural space, resulting in spinal cord compression. The axial cut showed that there was bipedicular involvement with extension into the epidural and paraspinal space. A CT-guided biopsy was done elsewhere, which revealed a vertebral hemangioma. Hence, a diagnosis of aggressive vertebral hemangiomas was made, and the question then arose, how should we proceed? There are a number of options available, which include transarterial embolization, ethanol injections, vertebroplasty, radiation, and a number of combination of these along with surgery. This talk aims to describe the current management of aggressive vertebral hemangiomas. Aggressive hemangiomas form 0.03% of the ubiquitous and commonly benign vertebral hemangioma. 2 to 30% of them are multiple, especially if they are thoracic hemangiomas. These aggressive hemangiomas are far more common in women between the age of 40 and 60. They usually start in the vertebral body and then go on to involve one or both pedicles and then spread into the epidural space and paravertebral tissue after causing cortical destruction. Histopathologically, a regular hemangioma is a slowly growing hematoma. It has dilated, thin-walled vascular channels which are set up in a stroma of fat, and these are interspersed among thickened bony trabeculae. Aggressive hemangiomas, on the other hand, have a lesser fat content and more of vascular channels. They result in a vertebral expansion and can cause spinal cord compression secondary to the expansion. They can also cause spinal cord compression because of epidural spread of the tumor. The first investigation, of course, is an X-ray, which shows you coarse vertical striations. The sagittal CT scan mimics the X-ray picture. The axial CT scan shows a polka dot appearance because of the thickening of the vertebral trabeculae. The T1 and T2 weighted MRI scan shows a signal hyperintensity because of the hemangioma. The T1 hyperintensity reflects the fat content of the tumor, whereas the T2 hyperintensity reflects that the tumor is full of fluid. Aggressive hemangioma is differentiated from a benign hemangioma based on the level at which it occurs. Aggressive hemangiomas occur between T3 to T10, are involved the entire vertebral body with cortical expansion. There is often cortical erosion and extension into the epidural space, paraspinal space, or into the posterior arch. The MRI in an aggressive hemangioma shows a hypointense signal on T1 weighted image because of the high content of vascular channels. And there is an intense enhancement after contrast. A CT guided biopsy is unnecessary on most occasions if the classic findings of vertebral hemangioma are observed. But sometimes there may be a doubt in diagnosis, and the differentials include metastasis, solitary plasmacytoma, and lymphoma, among others. The problem with CT guided biopsy is because there is such a large amount of vascular channels, little soft tissue is obtained for the study. Often one seems to extract only blood. Hemangiomas, based on their activity and their aggressiveness, are classified into 4 types. They can be latent with mild bony destruction and no symptoms. They can be active with bone destruction and some pain because of pathological fractures. Or they can be aggressive with epidural or paraspinal spread and neurologic deficit. The treatment options are varied and many. Direct ethanol injection into the tumor, transarterial embolization, and vertebroplasty or kyphoplasty have all been shown to work in terms of destroying the tumor, but they are meant only for tumors which are well contained within the vertebral body. Radiotherapy, on the other hand, is known to cause vascular fibrosis and impairment of the circulation of the tumor. Haid reported a complete resolution in 79% of aggressive hemangiomas after a high-dose radiotherapy regimen consisting of a total of 3,400 rads. The problem with this radiotherapy in patients with a progressive neurology is that their symptom relief often takes a fairly long time. And therefore, currently, radiotherapy is primarily indicated in the post-surgical setting to prevent a local collapse. It is contraindicated for large tumors and tumors invading the spinal canal that result in a significant neurologic deficit. Radiotherapy may lead to radionecrosis, myelitis, secondary sarcomas, and even vertebral collapse when there are extensive lesions. The surgical options for aggressive vertebral hemangiomas traditionally have been a simple decompression or a decompression with stabilization, or excision of the tumor, either piecemeal or en bloc, and a reconstruction. However, majority of the surgeries today are performed by a combination of surgery with embolization and vertebroplasty to limit the surgical morbidity. Between 2002 and 2018, we have treated 15 patients with aggressive vertebral hemangiomas. Majority of them were in the thoracic spine and half of them were associated with a pathological fracture. 13 of the 15 patients had mild to moderate back pain, which had worsened because of a pathological fracture in recent times. All patients had a neurologic deficit at presentation. In all our patients, we perform embolization 1 day prior to the surgery. We performed gross total resection in 9 patients, and this was followed by anterior reconstruction and posterior stabilization. Radiation was given if there was a paraspinal spread of the tumor. No recurrences were encountered at a minimum 2-year follow-up. However, when one performs gross total resection, which is a major surgery with morbidity, the blood loss is higher. There are more surgical site risk of surgical site infection. In fact, one of our patients died because of an esophageal tear and mediastinitis. In 2012, when I met Dr. Stefano Boriani at a conference in Budapest, he suggested that for a slowly growing tumor like a hemangioma with limited recurrence potential, a gross total surgical resection was an overkill. This made us think on our strategy, and from then on, we started performing surgery along with embolization, vertebroplasty. In case the patients had pathological fracture, we added posterior stabilization. Because we were not excising the entire tumor, post-operative radiation was mandatory. Why embolization? Embolization causes ischemic necrosis of the tumor and shrinks the tumor size. It reduces the intraoperative bleeding. Why vertebroplasty? Because it strengthens the vertebral body and relieves the pain because of microfractures. It kills the tumor cells and leads to intralesional thrombosis. It results in irreversible sclerosis of the hemangiomatous venous pool, and it reduces bleeding prior to decompression. When performing the surgery, the steps of the surgery include embolization, which is performed 1 day prior to the surgery. At surgery, having exposed the surgical site, a vertebroplasty is done before any decompression is attempted. The vertebroplasty is performed such that maximum filling of the vertebral body is achieved. Following this, posterior stabilization is performed, and then finally a decompressive laminectomy is attained. Transpedicular decompression was found to be unnecessary because once the embolization and the vertebroplasty is done, majority of the vascular channels seem to close down, and there was very little tissue that was then causing a cord compression. Here is an example of a 48-year-old lady who presented with spastic paraparesis. She had a pathological fracture and epidural spread of the tumor. She underwent a pre-op embolization followed by vertebroplasty, stabilization, and laminectomy. Between 2002 and 2018, we have operated on 15 patients with asymptomatic vertebral hemangiomas causing neurologic deficit. 14 of the 15 patients had significant neurological improvement on follow-up of 24 months. Most patients reported a significant improvement in back pain, and none of the patients had a local recurrence at 24 months. To conclude, when vertebral hemangiomas present to you, one tries to see, is this a non-aggressive or an aggressive tumor? If it's a non-aggressive tumor and non-painful, no treatment is required. If it's a non-aggressive treatment but painful, one can think either of medical treatment or vertebroplasty and occasionally radiation. If it's an aggressive tumor which is contained within the vertebra, then one can think of doing only a vertebroplasty and followed by radiation. However, if there is an epidural spread of the tumor, one would prefer to do embolization followed by vertebroplasty, then decompression and stabilization if necessary, followed by radiation 3 weeks down the line. Low-dose radiotherapy is always given to tumors when gross total resection is not done. Thank you. Yes, yes, Marcelo.
Thanks for your talk, very comprehensive. And I have a very difficult case, so it makes your talk was very useful for me. Let me ask you something. You make a very strong point about doing embolization always before your treatment. But in my experience, even though we have very good invasive radiologists, from time to time they tell us, I'm sorry, I cannot move forward with embolization because there's a common pedicle with a cord supply. How will this issue change the way you approach this problem?
It's a very, very good question, Marcelo. As you saw in our cases also, there were 2 patients who could not be embolized adequately because of the same reason. And these 2 were in the early phase of our study when we used to do vertebrectomies for these patients. So in that case, we just proceeded with vertebrectomy. The question is, how would we proceed today if we were not able to embolize? But today, most of this is taken care of by if we are still not able to embolize, we are still doing a vertebroplasty, which kills a part of the tumor within the vertebra and shrinks the size of the tumor. And then we do only a laminectomy and we leave everything else to radiation to take care of. So I don't try to go. What I found when I was doing these vertebrae, which Dr. Boriani suggested to me, was that even in these aggressive hemangiomas, a majority, even when the tumor has extended into the spinal canal, a majority of the time the posterior vertebral wall was solid and intact. And if you wanted to remove it, you actually had to fracture it and punch it into the vertebral body. So therefore, the vertebral body is intact. It is the vascular tumor which has just come out from there. So we have been very safely doing vertebroplasty in these patients and stabilizing. So if your patient, their embolization is not possible, I would still suggest the same protocol along with radiation postoperatively.
Gautam, any special tip to do the vertebroplasty in this particular kind of lesions?
Any place of?
Any special tip?
Yes, so I always do a bipedicular vertebroplasty in these cases because I want to fill up the vertebral body as much as possible. So I try to do a bipedicular vertebroplasty in order to achieve as much fill of the canal as possible. The vertebroplasty is always done before we do the decompression procedure in these patients so that bleeding is less during the decompression procedure. And I try to fill up right from the superior end plate to the inferior end plate.
Thank you.
Dr. Gautam.
Yes.
Sir, Dr. Dave had a question in the chat box.
Yes.
So there's dead space created. How do you circumvent it?
No, that was for he had a question for the previous thing, which was answered by Dr. Bernasconi. Here there is no dead space created. Here there is less space created. Don't worry. But in any case of recurrent hemangioma following, as I said, in my series, there were none of my patients had any recurrence at 2-year follow-up. I know that a couple of friends of mine from Bombay had patients who had recurrence when they had refused a radiation postoperatively after this kind of a limited surgery. And these patients had to be, again, one of them was tackled with a repeat vertebroplasty and then radiation. And another patient who was treated by somebody else underwent a corpectomy and fusion in this patient, anterior plus posterior.
So Menon wants to ask a question.
Yes, I think that will be the last question because we are running late. Yes, Dr. Menon.
Gautam, I have 2 very quick questions. One is, you mentioned that the posterior wall of the hemangioma is always intact.
Is usually intact. That's what my finding is.
If the posterior wall is not intact, what would you do? That's the first question. The second question I have is, what do you do in pregnant women? Because this is very frequent in pregnant women. I've had 3 cases so far, so I just have a doubt as to what to do.
So if the woman is pregnant and if you can treat it, the biggest problem in these patients is that if they are treated, they present with acute neurology, there is very little you can do. Every part of the procedure requires radiation. So whether it is embolization, whether it is vertebroplasty, then you are left with very little option but to think of a major surgery. I've had 2 patients, but both of them luckily had delivered and then came up with a vertebroplasty with the problem. So I haven't had that encounter as yet. Answering your first question, if the vertebral wall is not intact, what can you do? I think one patient very recently, what I did was I was still able to manage doing a vertebroplasty on one side. But in that patient, what I did was I first did the decompression and then did the vertebroplasty under observation. and still tried to fill the canal. And because I had kept the posterior wall, whatever was there intact, and gone down one pedicle to decompress, there was no leakage of the cement into the canal. I haven't encountered any serious problem, but I suppose if there is a significant posterior wall breach, that's worried.
I'm fine.
Any other questions from anybody else? Yes.
Gautam?
Yes, there is a question.
Gautam?
Yes, we
chat box. A role of biopsy to confirm the diagnosis and the risks involved.
So that, as I mentioned, I think in my talk, that biopsy unfortunately is not very productive often, because the whole tumor is made of vascular channels. So when you go in there, you get a lot of blood. You don't get bone, or adequate biopsy is very common that you may not get an adequate biopsy. So that is there. And however, in the limited series of 15 patients, most of the patients are diagnosed based on the radiological picture. Literature says, however, that a CT-guided biopsy, if and when done, has not resulted in any significant complications or hemorrhage in these patients, in spite of the problem that one would think one would encounter. So yes, you could do a biopsy, but the chances that the biopsy will be successful in yielding a diagnosis are not very high. As I said, we are running very late. We have to move forward, and I request Dr. Marcelo to invite the next speaker.
Thanks. Well, for me, it's a real pleasure to introduce Gaston Camino. Gaston used to be our resident, 10 years ago. Now he's in his way to be my boss. We started doing this procedure he's going to describe a couple of years ago. One of my partners, Carlos Solá, learned it from Peter Varga. But Gaston moved forward with this technique, giving really a scientific background. So he's the ideal person to talk about this procedure, discoplasty. Gaston, are you ready?
Hello to everybody. Thank you very much. My name is Gaston Camino Vilugar. I am from Argentina. I work at Hospital Italiano de Buenos Aires. And thank you very much to the Association of Spine Surgeons of India for this invitation. I am going to talk about percutaneous cement discoplasty, our institutional experience. These are my disclosures and conflict of interest. Before start talking about this procedure, I want to mention some changes that need to be understood, such as the intervertebral vacuum phenomenon. As is observed in these pictures, you can see that this space is start filling with vacuum phenomenon, which is the presence of gas or air within this space. This is a classic example of initial stage of vacuum phenomenon. We call it minimal vacuum phenomenon. Then, in some cases, the vacuum phenomenon is more advanced to a stage that is called intermediate or partial vacuum phenomenon that can be present with or without subchondral sclerosis, as you can see in the right picture. And finally, in some cases, we observe like total intervertebral disc space covered by vacuum phenomenon. We call this a total vacuum phenomenon or more advanced stages. And this classification of intervertebral vacuum phenomenon was published by our institution, our group, last year. So, what is known about percutaneous cement discoplasty? Well, this is an alternative to treat low back pain in elderly patients, especially in those patients which are frailty, in which conventional fusion techniques are probably risky, associated with higher risk of complications, and also this technique has shown to improve low back pain, at least in the middle term follow-up. These are the three main indications when considering this technique. At least in our institution, we consider the mechanical low back pain. We call it the pain that is increased by activity and a standing position and is partially relieved by resting position. Another indication is the presence of vacuum phenomenon, especially the partial and the total vacuum phenomenon are considered for us as a clue when treating these patients. And the accordion phenomenon is the change in the scoliotic curve. When you compare it, the standing position, as you can see in the left image, and the horizontal position, the CT scan. If there is a change in the angulation, we call it accordion phenomenon. We also consider this as an indication for percutaneous cement discoplasty. This is the technical procedure. We put the patient in a prone position and we insufflate a roll below the knees in order to produce an hyperextension and increase the lumbar lordosis, as you can see in the picture. After that, we use an extrapedicular access, mainly through the triangle, the Cambin triangle, and we access in the corner, in the superior and lateral corner of the pedicle, and we use neuromonitoring in order to at least prevent or avoid nerve root irritation when inserting the cannula. You can see in the pictures how the cannula is placed and how the cement starts filling the gap, the vacuum space. This is a case in which you can see the partial improvement of scoliosis from 25 degrees to 11 degrees, and also the improvement of lumbar lordosis. We believe that this is because the hyperextension in the position, as I mentioned before. So radiological parameters are improved, at least partially. The most important is the improvement of clinical parameters as well. This is a case, an 82-year-old male with a severe scoliosis and spinal imbalance, and you can see, and cardiac disease. This patient is not a candidate for a fusion traditional technique because I can guarantee that this patient is going to suffer some mechanical complications secondary to a fusion surgery, besides some clinical complications. And we believe this is a classic candidate for a percutaneous discoplasty, in which our goal is to partially relieve the patient's pain. But to be honest, we don't expect to improve all the pain. In this case, the patient has a low back pain in a rate of 10, 7 out of 10. And as you see in the picture, we use the percutaneous discoplasty and fill four these spaces. And you see in the postoperative control how the radiological parameters were improved, and partially. And the most important, the back pain was improved from 7 to 3 at 1 year follow-up. So we believe that for this patient, the technique was really successful. However, what is not known about percutaneous cement discoplasty? Well, this is very important because we need to understand the limitations of this technique. We lack of long-term outcome studies. The real mechanism of pain reduction is not completely understood. We believe that this is because the spacer function within this space, and we don't have level 1 or level 2 evidence studies about this treatment. So this is mandatory. We need to have better quality studies about this. But this is the current evidence that we have from Vargas Group from Hungary. They published the technique, and also they showed improvement of radiological parameters, and they show the indirect foraminal decompression due to the stabilization technique. So they consider that this technique is also can improve the radicular pain, not just published the technique is similar with access entry point. We use the pedicular entry point in L5S1 level, at the lumbosacral level, and they show improvement in back pain and clinical parameters such as the OS3 at 2 years follow-up. This is our experience. we first published the technique with some variations from the original one, which is mainly based on the changes in the hyperextension of the lower limb in order to improve the lumbar lordosis, and also the use of neuromonitoring, which is still under debate, but is in order to decrease the rate of neurological complications associated to the introduction of the cannula. And we published a case series analysis with 54 patients with 1 year follow-up, an average 1 year follow-up. And we observed a pain reduction of almost 50% and an improvement of the OS3 disability index as well. And then we published the classification of vacuum phenomenon, pointing out that the main indications should be at least a partial vacuum phenomenon, and the best indication should be a total vacuum phenomenon, because the spacer function is going to be more visible in the when the disc space is totally degenerated. With the more vacuum you have, the better feeling within the disc space. As a summary, percutaneous cement discoplasty could be considered as an alternative when treating low back pain in elderly patients, especially in cases in which traditional fusion techniques can be associated with risks of surgical complications and clinical complications. And we have shown an overall 50% of pain improvement. So this is a satisfactory outcome for us. For sure, we need future directions, probably technically related, to improve the intervertebral spacer, maybe not cement, maybe more elasticity or elastic substance. We don't know yet. And of course, we need a better knowledge about which patients will be benefit from this technique. And so improve the indications and longer follow-up studies, and in addition to higher quality studies, in order to understand the real benefit and pros and cons about this percutaneous technique. So thank you very much for this presentation. I hope you understand the technique and can use it in the future. Thank you very much.
Thank you, Dr. Camino, for an excellent presentation of this new technique of discoplasty for degenerative discs in elderly patients. The talk is open to the house. Any questions from the audience or from the panelists?
Sir, Dr. Bharat Dave has a question.
Yeah, Dr. Dave, please ask.
Choice of access, left or right?
For what?
So the discoplasty.
Would you access from the left or right, Dr. Camino?
It depends on the patient's X-ray. We usually try to go from the convex side in an scoliotic curve, but you have to see when the patient is put on the prone position. The more interpedicular space you have between the two pedicles, is better to avoid, especially to avoid the nerve root, to avoid the injury to the nerve root, right?
Another question is, how do you control the cement leakage in these patients? Because one would expect annular tears in these kind of degenerate discs.
Well, this is a really important question, because we have observed some leakage in cases in which patients were operated with a microdiscectomy or an annular tear in the disc space. So we have to be very careful in those cases. But we usually prepare and mix the cement and wait at least 4 or 5 minutes before starting to introduce through the cannula, in order to avoid to insert the cement too liquid. We try to make it not too liquid,
Another question, Dr. Camino, from the delegates is, any incidence of late breakage, fracture of the cement and displacement into the canal?
We observe so we had some cases with semen leakage in the canal. Most of them were asymptomatic for sure, but we had some nerve injury due to the cement as well into the pedicle and things like that. So it's very important to be careful when inserting when preparing the cement, and during those 5 or 6 minutes in which you wait to the cement to be more solid.
Right, a final question from Dr. Bernasconi, and then we move on to the next session.
Yes, a very good presentation. Congratulations. I have 2 questions. The first is that if you're taking care the joints, do you do any block test before do it, the cementoplasty? And then if you're taking care, but you already mentioned now, the spinal canal after the procedure to try to measure the indirect decompression. That's what the real question.
Thank you very much, Dr. Bernasconi. Well, the second question, we didn't measure the spinal canal or didn't consider it, as the change in the lumbar lordosis is small, is probably between 5 or 10 degrees. Is an important question, and we should consider it in the future probably. And the first question, can you repeat it, please?
It's about the facet joint, because you're taking care.
Thank you. Yeah, no, we don't perform pre-operative block injection. We consider the mechanical back pain, and we hope these pains could be produced by this disc space.
Thank you very much, Dr. Camino. And with that, we come to an end. I hope that you've enjoyed this session. I think there was a lot of learning points in this session. And I would like to thank my co-moderator, Dr. Gruenberg, for this session, for joining me and helping me coordinate this session. I moved quickly to the next session, which is a very exciting session of case discussion. And the moderators for this session, Dr. Basu and Dr. Emmerich, and I would also request Dr. Menon, who is now here, to join us for chairing this session. And I invite the panelists, Dr. Gruenberg, Dr. Petracci, Dr. Shankaracharya, and Dr. Satish. Without much ado, can I request Dr. Shankaracharya to start the presentation?
I welcome my co-moderator, Juan Emmerich, and he may please invite his Argentinian colleagues, as I invite Dr. Shankaracharya, is the incoming president of the ASSI, to deliver the first talk, an interactive case discussion on a rare case of a laryngeal palsy in a cervicothoracic tuberculosis.
Good evening, everybody. It's good to see you all. I don't even remember if Marcelo Gruenberg remembers me, but he gave me a picture of a lake, which is very silent, and then suddenly a crocodile jumps right vertically up. And this is such a case where I got stuck. So this is one of my big complications recently. So when Gautam asked me to talk about it, I thought this would be a good case to do. Can you hear me?
Yes.
Perfect.
This is a 14-year-old girl, with no more comorbidities, absolutely fit and fine, with neck pain and difficulty to move since 2 months.
Sir, please share your screen, sir. Please share your screen.
You can't see my screen?
No.
Yes, not yet.
Oh, yeah. 1 second.
Should we move on to the second presentation and come back to you, Shankar?
Yeah, you can do that.
Yeah. So let us call Dr. Satish. Satish, can you please share your presentation here?
Yeah. Can you see?
Yes.
Yes. Yep. Good evening, everyone. I will straight away go to this unusual case of thoracic myelopathy. So here is a 19-year-old male who came to me 6 months with a history of left lower limb weakness, occasional buckling of the knee, and altered walking pattern of 3 months. And it all started when he started, he was leg press, he did 200 kg because he was weighing himself about 120 kg. He wanted to reduce his weight, started going to the gym, and started, this problem when he once did a 200 kg leg press. And it progressively worsened over a span of 6 months. So his motor power when he came to us was 4/5 in the left lower limb. Proximal was much more weaker than the distal. He had a bilateral exaggerated deep tendon reflexes and has spastic gait. And if you see this gait, he used to walk like this, literally, and sometime both the knees used to buckle. So he used to drag left lower limb more than the right lower limb. So clinically, he had a classical thoracic myelopathy with a predominant motor weakness. And this is his MRI. Okay, can anybody wants to comment on this? Basu?
Yeah, Shankar, I think you can start off being one of the important panelists. You can just leave a comment before Satish can move on.
Yeah. Gautam, you want to take this?
Yeah, I'm not one of the panelists, but we can ask Marcelo. Marcelo, what would you do for something like this? What is the diagnosis here?
No, I really appreciate you bring up this case because in almost 30 years of practice, I only saw one case exactly the same as you are showing. And to tell you the truth, the first time I saw it, it was very difficult for me to understand the image. Luckily, in this case, you see the cord moving forward, so you can make some sort of deduction of what is happening. In my case, there was some mild kyphosis, so you don't really see the cord moving, and the differential diagnosis in the image was very difficult. The good thing of bringing this case is that once you see one case of this, you will never forget it. So in case one of our colleagues come in their practice across one of these cases, they will always remember this presentation. When you see it, you realize that it's a typical presentation of this pathology. I don't want to move forward in what I see because I don't want to open the case too early.
So before Satish moves on, one thing is of importance is that the CSF column suddenly increases in its posterior aspect and the cord shifts anteriorly. That is very typical of a spinal cord herniation. Satish will move forwards, please.
Yeah. So, ultimately, it is definitely a case of spinal cord herniation. What is important here in the scan is you see the cord changes, which is there is a myelomalacia change anteriorly, and the dura, there is a small break in the dura anteriorly. So, what to be done next? It is a classical case of ventral herniation of the thoracic cord at D7 level with thoracic myelopathy. Yuan, you have anything to say? What to do next? How do you approach this?
Hi, Satish. First of all, it's a pleasure to see you again. So many years. It's a huge honor. You look so fancy today. As Marcelo says, I only see one case of this in my life because they're very, very, very infrequent. And it's not so easy to make the diagnosis. I am so proud here that everybody looks like a piece of cake. For me, it was a huge challenge at that time make the diagnosis, because even was a youngest patient, have 16, 15. So we think it's something malformative or another thing. The issue here is you need to try to fix that problem, because that will be worsening this. As again, I believe everybody says that this looks like idiopathic herniation of the spinal cord, and you need to fix that problem as soon as possible to protect the spinal cord.
Okay. So we planned in the following manner that we wanted to do the pedicle screw fixation at D6 to D8 level, D7 laminectomy, D7 one-sided pedicle excision, and exploration of the anterior dura, because unless you take off the pedicle, you cannot go to the anterior part of the dura, and identification of the defect in the dura, and repositioning of the herniated cord back to the canal, and ventral duroplasty, with fat and graft, all to be done under neural monitoring.
Satish.
So this is how we started. Here is a small video. Pedicle screw was applied, cephalad and chordate, and I drilled the pedicle on one side. I did completely unilateral approach. I drilled the pedicle to thin it out so that, I'll come closer to the bottom of the vertebral body. This is the baseline, MEP. Then the dura is opened from the posterior, and that is the arachnoid I'm opening. And you can clearly see there's a cord is completely gone in. There is a depression there at one point, and that is a dentate ligament. You have to cut the dentate ligament at 2 levels before you open. So when you dissect the dentate opening, you can clearly see there is a depression, there's a hole in the anterior dura, and the anterior part, the cord is completely sinking in. So you have to make sure the dura is flat. See there, that is a cord. Constantly you have to monitor this thing. That is a sclerosed cord which has gone in, and there is a dural defect. And this is the herniated cord, which I slowly moved it forward. It is almost like a tonsil you see in a case of foramen magnum decompression. That is a sclerosed cord tissue. And then after lifting, in that gap, I filled the fat because we had to literally fill it, and then put the graft, pull it from the other side. This is a fascia lata graft. I put it above and below the defect so that it will go to the opposite side. And the graft has to be stitched, otherwise it will float off because of the CSF anteriorly. So then we closed it. So when I closed it, it's perfectly all right. And MEP at the end was as normal as anything else. So everything went on well, as planned. And in the post-operative period, the immediate post-operative, there's absolutely no neurological deficit and no alteration. But I kept, because the herniated cord has come out and the canal is adapted to the new cord, the canal will be definitely tight. And because of the handling, I was definitely expecting some edema, though he was completely neurologically normal. In addition, he was a very obese person. So on the first post-operative day, at 6:45 a.m., I got a call from my resident saying that patient is feeling heaviness of the numbness in the bilateral lower limbs. And at 7:30 a.m., his power dropped to 3/5 and severe spasticity. And the next, I had already scheduled an acoustic schwannoma to operate on the same day. When I went at 8 o'clock, this is the scenario. So what to be done next was a question for me. So can anybody tell why did he worsen?
Satish, before going on to worsening, why did he worsen? I think the next step would be sort of an imaging. Could you arrange for an emergency imaging?
So we arrange for the imaging. Imaging, I'll show you. And what are you looking at the imaging?
Is there a hematoma?
Okay, then?
That would be impossible because how good a surgeon you are.
Yeah, it is unusual because I've done a clean surgery. So I'll tell you what happened, okay? And how to go about it.
Buckling of the fascia. Buckling of
the fascia. Inside, buckling of the fascia. Okay. So this is, in the post-operative period at 8:30 a.m., I gave a methylprednisolone to him, and I canceled my previous surgery. And serial assessment was done, because I had already started the surgery. So power worsened by 9 a.m. and 11 a.m. Completely further worsening because the other case was started. So I had to do both the things. And we gave a small sedation to him, Dexam, and bedside we did a MEP. The MEP showed the preoperative on the left side, and the post-operative at 11 a.m., there is a flattening which is happening. So in the ICU itself, I did it. MEP showed a complete absence of waves in the bilateral lower limb. Then I came out of the surgery, and this is what went through this thing. Clinically, Asia D to Asia B, despite starting the steroid therapy, MEP showed no conduction across the cord, and this is the imaging which we did. The imaging showed there is no hematoma. The fat graft I put was all right, but I found small edema within the cord. And because of the pedicle screw, there is complete disarray of the imaging. But only thing is my radiologist said there is no hematoma at all. So what I did, I took him back, to the OR, Then family counseled. They were completely worried. Patient was taken to the emergency exploration. And this is the MEP immediately before opening. So I opened the dura. As soon as I opened, you see here, the cord is normal. The facial attack graft, which I put at, I took extra, I did not do the grafting at that time. I closed with the same normal dura. As soon as I opened, the MEP came back. So it's purely because I had not done a duroplasty, thinking that it was very lax because the CSF was let out. That gave me the pseudo feeling that the cord can accommodate this dura. And when I closed it, primary closed it instead of using the duroplasty. So the CSF letting out made a pseudo feeling that it can accommodate even the herniated cord when I brought it back. So as soon as I opened, this is the before opening the dura. After opening the dura on the right side, MEP came back. I just did the duroplasty and I came out. He was, this is ultrasound I did peroperatively. Absolutely no hematoma. There is only mechanical compression of the intact cord at the posteriorly, and anteriorly there was a mechanical pressure. So intraoperative monitoring, after opening the dura, it improved, and I did duroplasty. First post-operative, he became grade 1. Sensation came back and started mobilizing on the second day itself. Family was counseled. He was 120 kgs. After 1 week, patient was moved to the rehab, constantly spoken to them, and he was sent home on the 2 weeks. They started rigorous physiotherapy in their place. He had come from Gujarat to me. And at the end of, the 1 month, his power started grade 3 to 4. And this is his video at the end of 1 month. He started walking. This is at home at the 2 months. He was still spastic. Buckling was there, but he could manage. He lost nearly about 20 kgs in that 2 months. And this is at 6 months. And he started riding the bike at 6 months. And today at 6 months, you can see the cord is completely free. CSF is flowing both front and back. There's a mild kyphosis, but he's back to normal. So what could I have done better is the muscle patch instead of fat, because the fat, what happens with the CSF, it expands. Whenever I crushed it, but any fluid which is there, the fat expands and it acts as a mass lesion. And I should have done a primary duroplasty, but I did a primary closure without a duroplasty. So that reduced the tissue space and created a problem to the patient. And the learning curve is unique case. I had to be prepared with unique problems. And neurological worsening, I should have anticipated. I really anticipated. Early detection was the key, and the team managed very well. Proper use of technology in the teamwork made enormous difference to this patient. And family luckily accepted all the things which I said, which gave me calmness, and they were not at all perturbed. They believed in me, and it worked in my favor. And periodic communication on the WhatsApp and videos and communicating with them made enormous difference even to my psychological boosting, and remained positive throughout and made a difference to me. And we did publish this, and it was a unique case with a unique solution. Thank you very much.
Thanks, Satish, for a very interesting case. We'll accept only 1 or 2 questions. We have 1 minute to go. I'll start off with the first shooter, that it was a fantastic case, fantastic follow-up, excellently managed. But again, it's always that we think better when the job is done. So it is very easy to think about the fact that it is very a simple logic that if you put something in the intradurally and you do not give them space, obviously the thoracic cord, as it is, doesn't have much space, it gets compromised. So any question from anybody, please go ahead and ask. Yeah, please. Yeah.
Yes, more than a question again, Satish, congrats. This is really great. I believe the important here in this case is how you deal with the complication, especially to have an early diagnosis and don't waste time, go straight to look for a solution. After that, when you open the dura again and you can see the spinal cord or hematoma, you have some time to think and try to understand the physiopathology. But if we spend too much time trying to understand and we don't be operative in this particular case, this patient probably could have a much worse neurological lesion. So congrats. The thing what happened don't have too much explanation. Could be perhaps, the flap move a little bit. Perhaps as you already can say, perhaps you can do a duroplasty for the first time, but I am not sure if that will be the solution. The important thing here is how you deal with the complication, and that is amazing. Congrats again for that, but that's really great job.
Thank you.
Gautam, you are fabulous.
Thanks, Satish. Is Shankar ready with his case, or shall we ask Professor Emerish?
Yeah, let us ask Professor Petriacchi. Okay. But whilst Professor Petriacchi loads his case and shares his screen, Satish, when you went in the second time, were you pretty sure what had happened, or was it just that it was an exploration? I mean, would it have been a situation that you went in there and you might not have found anything to correct? What would have happened then?
No, I was pretty sure that there's a cord edema because it's a slow, deterioration. And the second thing, I knew the amount of the fat I pushed in. I was pretty sure because, this fat usually expands whenever there's a fluid one. So I was very confident because as soon as I opened, MEP came up. So I knew that it was just a cord, like a brain. Normally when we do the stroke and everything, we know how it reacts. Similar way the cord reacted, and I was pretty sure there is nothing else which was happening.
Right. Thank you.
And the other thing I thought is when the cord I rotated, because it was anterior, right? And I rotated to the left side to bring it to the surface. So I was only hoping that there is no squeezing of the spinal cord. But as soon as I opened, I gave extra space. I made a big duroplasty, and which definitely made a difference to me. But I knew what exactly I'm going to do.
Dr. Petriacchi.
Hello. Thank you very much for the invitation. Good evening to you, to the Indian surgeons, and good afternoon to the Argentinian colleagues. I will present this case. This is a patient of 41 years old who present during the quarantine lockdown in Argentina on May 2020. He had a motorcycle accident. He had a motorcycle accident, neck and shoulder pain without neurologic compromise. He wore a helmet during the accident. And at the moment in the emergency room, he was hemodynamically stable and doesn't have any comorbidities. This is the X-rays. Here we can see an AP and lateral cervical X-rays, an open mouth X-ray, and a shoulder X-ray where we can see a clavicle fracture. At the X-rays in the cervical spine, we cannot see very well what is happening, but the patient complains a lot of pain, a lot of neck pain. And when we did a CT scan, here we can see different fragments or fractures in the body of the C2. Here we can see some lines that goes in the sagittal view. Also in the frontal view, we can see this and some fracture that goes and affect the facet joints between C1, C2, and also some part of the pars of the C2. The MRI didn't show any problems of the ligaments. Here we see different cuts at the MRI. And why I put like a typical fracture? If we try to fit in the classical AO spine classification, we should put probably at this type of fracture, but it doesn't say how much the comminution how we fit the patient in this classification. Also, we have to classify this classification in type A, B, or C. We say that it's type A, but the OS spine classification shows that this kind of fracture are stable injuries, and I'm not sure this is this kind of stable injuries. But it has modifiers, and probably this modifier helps to understand that some kind of fractures could be unstable. But at the moment, we don't know if this fracture is unstable or not. That's why I found this classification that is a very old classification in '94, and they classify the body fracture of C2 in vertical lines in the coronal plane, sagittal plane, or lines that goes transversally, like a chance fracture. But it doesn't classify the comminution fracture of the body. Later, 2 years later of that classification, Fujimara puts the burst fracture of the C2 like a part of the classification, but they didn't explain which kind of burst fracture should be stable or not. Probably we have to combine like the Anderson and Alonso classification and say that probably this patient has some type of type 3, and if we go to the Hangman classification of Effendi, probably is a type 1. But this patient has a combination of these kind of fractures. And maybe this can help us, that is the classification of subaxial spine, that where a burst fracture could be stable or not, and probably when the comminution goes at the facet joints, maybe we should classify as an stable kind of fracture. In summary, we have this case that has this kind of fracture, and maybe we can discuss if we go for a conservative treatment or a surgical treatment. And if we go to the conservative, which will be your option, or if we go to the surgical treatment, which will be the options. I don't know if you want to discuss this, or I should continue with the resolution.
Yes, let's put the question to our last speaker, Dr. Satish. You are an expert in C2 fracture fixation. Please, how would you treat this patient?
I will go with the halo vest for this patient.
You will keep a halo vest for how long? About 3 months?
12 weeks.
12 weeks, 3 months, yes. Dr. Menon, you have an enormous amount of publication on C2 and hangman fractures. This is similar in that. What would you do?
Yeah, in my practice also, I would prefer to do a halo vest.
Yes. I think majority of the patients, people, and what about you, Dr. Bernasconi, what would you do?
Hello.
Yes.
I think that is a good opportunity to do an internal fixation and transitory internal fixation for 6 months, and then remove the implants. It's a good option to prevent the rigidity at the C1, C2, and at the occipital cervical level.
So you would
we are doing
screw?
Yes, with the screw. We do the internal fixation without fusion, without bone, to try to restore, especially the sagittal plane and the distance between the joint, the CO, C1, and C2. And then we removed the implant 6 months ago, after the complete consolidation. It's a part of the body, the upper cervical spine, with a good consolidation rates. So it's a good option that we are doing since 2 years.
Marcelo, a last point before we get Dr. Petracci to show his solution.
Yes, I see that all the panelists agree in the treatment because they all propose some sort of temporary fixation, internal or external. But here my question, and I would like to hear the opinion of Satish and all you that have a lot of experience, is really which is the how will you classify, how will you put this fracture in your mind to understand the mechanism, and following that mechanism try to propose a treatment? Because for me, Matthias make a good point. This is more close like a type A4 of a subaxial injury that compromise the whole body of C2, especially both articular surfaces. And I think that even though this fracture has the potential of healing, it also has the potential of get deformed before healing. So I agree with that. Both methods are good options. But what do you think about the mechanism?
Dr. Menon is our biomechanical expert. We'll get him to answer that question.
There is a Hangman-oid element if you look at the axial section, in the sense that the fracture is running through the pedicle, at least on one side. But I think it's predominantly a vertical compression, a pure vertical compression injury like a burst fracture. So you will find that in the coronal pictures, the facet joints of the C2 and the subchondral bone thereof is split vertically into multiple layers. So that tells you clearly that's it's an axial compression kind of injury. There's very little flexion or extension mechanism here, because posteriorly the spinous process or the posterior elements of C1, C2 have not separated out. The facet joints of C2, C3 have not opened up. So there's hardly any flexion extension mechanism. So this is clearly an axial compression injury. So that's which is essentially, to my mind, a stable injury, barring what Marcelo said, that could be late deformity. So you need to probably jack up a little bit of height and with your.
Thanks, KV. But Dr. Petracci, your solution, please.
Okay. I suppose we will discuss all these things, but we didn't do that. This is other patient. We didn't do that. That is internal fixation of the C2 Hangman. That is other case. And also we didn't do that. That is for other kind of fracture that could be in a Hangman fracture, but we had a lot of comminution here, and that's why, and the C1, C2 facet joints also were involved. We didn't do the allo-vest, that maybe will be the first option, because the patient didn't want it, and also because he had a fracture at the clavicle, and probably this will be also inconvenient to wear a helmet. Also, we didn't do that. That is double approach and very unstable Hangman fractures. That the patient had two approach to consolidate. And what we did, it was a temporary fixation in C1, C2, and a C2, C3 facet fusion, all by a posterior approach, as you see here. This is the X-rays, where we can see the reduction. Probably this was not a good idea to put this screw here, because I think it didn't reduce the fracture and maybe push it to the front. But we see the reduction of the facet joints in different planes. And as you see, also the clavicle fracture was operated. This is the 20 days post-op control during the pandemic quarantine. We had the opportunity to do telemedicine. And now is 8 months post-op. The patient has a limitation of rotation of the head, as you see, and no deflection extension. And this is the X-rays at 8 months. Where we see the healing process and the MRI that doesn't show any inconvenience, and the CT where we see that the fractures is still starting to heal. The facet here seems to be pretty well, and more here we can see the fusion of the facet joints in C2, C3. And the reduction or the gap here of this facet joint that I think is good. And here we can see a comparative CT scan between pre-op and 8 months post-op. The C2. And here we are at this moment, 8 months post-op. And the discussion will be, should I now remove the instrument, the pedicle screws or not? I didn't do this yet, maybe because I'm waiting that this gap fills, but probably I will do it in the next months. Okay, this is the end of the presentation. I don't know if you want to comment something.
Can I say something?
Yes, sure.
Please, Kevin.
So if you look at, can you show the previous slide, please? The one before. So if you look at the preoperative coronal images, you will see that the facet joint is actually the C1, C2 facet joint, which has been disrupted and which is irregular. It's not the C2, 3 facet joint. So though it's an excellent technique that you have presented, I'm just wondering, what was the rationale of using the C2-3 and not the C1-2? Because here's the C1-2 is what is disrupted. If you're liable to get arthritis in the future in any joint, it's the C1, C2 joint rather than the C2-3.
This was for a support at the C3, and the fusion in C2, C3 will not affect the mobility of the cervical spine, and I prefer to have another point to support below the C1, below the C2 facet joint. I think that this like a floating facet joint.
Thanks. I think Dr. Petracci, it was a very atypical case, and for the brevity of time, I will invite our next speaker. My co-moderator, Dr. Emerish, can please invite and introduce the next speaker?
Yes.
Who is Marcelo Gruenberg.
Yes. So Marcelo Gruenberg is a young surgeon from Argentina. He's probably a rising star in the future. We need to have some patience. But I believe everybody knows Marcelo. Marcelo is one of the big shots here in Latin America, not only in Argentina. And always it's a pleasure to share some experience with Marcelo. And Gotan, before Marcelo speak, we are a little bit jealous, the Argentinian surgeons, because you not only have a C2 expert as Satish, you even have a C2 expert in biomechanic in rare fractures on C2. That is amazing. That is a good thing. You are so many, you have especially experts for every little thing. But it's amazing, Dr. Menon. Your comment was really nice. So, Marce, if you want to start with your case.
Yes, I am sharing my screen. Are you able to see it?
Yeah.
Okay, excellent. Well, this case, I brought it because it will complement Gaston's previous presentation. This is a case that represents really a good portion of our degenerative cases at the Italian hospital in Buenos Aires. Our population is really old, but they want to remain active, and this is a clinical problem we face very commonly at our office. This is about a 76-year-old female that basically complains of chronic low back pain, but is very severe and actually is making her regular life almost impossible. She also has a sciatic pain since a couple of months. On physical examination, the low back pain is 8 in 10, and the right sciatic pain that reflect the trajectory of the L5 dermatoma with no deficit, relief completely at rest or sitting. As you see, the background of this lady is pretty poor, but this is the regular patients we are seeing at our office. So let me show you the raw images of this lady standing. You can see the frontal and sagittal imbalance. You can see a very severe degenerative disease at the lumbar spine. To put numbers on this, you can see the double curve, 33 to the thoracic, 36 to the lumbar. And on the sagittal plane, you see a very severe 16 centimeters SVA and a mismatch between the pelvic incidence of 68 and lumbar lordosis of 28. The patient is trying to compensate that with a 26 hypokyphosis thoracic curve and trying to move her pelvis as much as he can, but she's obese, so another point against us. On flexion extension lying x-rays, you clearly see that she recovered a plenty good amount of lordosis on the extension, and you can see how the discs collapse in flexion. There's not much to say about the bending films. The thoracic curve is more flexible, as expected. Here you have with numbers for the thoracic curve goes from 42 to 7, and the lumbar curve moved from 40 to 30, as expected also. As you will probably expect, several degenerative changes on the lumbar spine with several foramen with stenosis, some central canal stenosis also. Just to have a view of the axial canal, you see stenosis at L3, L4, L4, L5. Remember that the clinical symptoms match an L5 root compression, so that can be in the central aspect of 3-4 or a more lateral aspect of 4-5. Interesting to see that when lying for the CT, the lordosis improve a little, and you see how the disc open, showing a nice example of the vacuum phenomenon of which Gaston told us about before. This is what a more detailed view of what we describe as a vacuum accordion phenomenon. For you, if you don't know, accordion is a typical Argentinian instrument in which there is a place of the instrument that expand and contract, sending air to other part of the instrument to make the noise. So you see, when you see the X-ray and then you see the CT line, you can imagine this accordion phenomenon of the spine collapsing and extending. To measure this on the frontal plane, you see clearly that from a 36 degrees standing scoliosis, the patient moved to 11 degrees curve just by lying. The correction is seen better here than in the bending films that explain the accordion phenomenon, the axial instability. So in summary, 67-year-old female with several comorbidities, with the main symptom of chronic, severe, incapacitating low back pain, and a secondary right sciatic pain that improves at rest. So at this point, I think we can start discussing about which are the treatment options for this lady.
Yes, Marce, thank you.
Yeah, I would invite any one of the moderators, Shankaracharya, to comment on the case and tell us what are the treatment options.
Thanks, Somajit. I think this is a degen scoli, which, as Marcelo has shown very nicely, that on lying down itself, it corrects so much. So I think obviously the ideal would be to jack up from the front. So if you can do multiple O lifts or A lifts and then do a posterior fixation, that would be ideal, which would be probably more minimally invasive. But in my hands, I would probably do an S2, LR2, T11 fixation and use multiple level T lifts or lifts in this case.
Okay. So any other options available to any other moderators? KB, would you put in a comment?
Yeah, I would probably do something very similar. not very good with O-lifts, so my approach would be almost entirely posteriorly, and with perhaps T-lifts at the bottom, L5S1, the others I would just do posterolateral fusions.
So anybody would consider any MIS techniques?
I will do OLIF. I will do 3-level OLIF, and then percutaneous screw fixation for this patient.
2 to 1, Satish?
I will do mainly 3-4, 4-5, and 5S1.
So it's a posterior MIS from 2 to 5 or 3 to 5? 3 to 1. 2 to 1 or 3 to 1?
2 to 1.
2 to 1. So your choice would be OLIF at 2, 3, 3, 4, 4, 5, and posteriorly L2 to S1 percutaneous screws with the MIS T-lift from the back at L5S1. Am I correct?
Correct.
Right. So can you go ahead and show us further about the case?
Yes, thanks. I think that the opinion of the panel reflects that even though everybody wants to do the same, recover lordosis, fuse the more degenerative aspects of the spine, the different alternatives show that there's not clearly one good option for an obese patient with osteoporosis in which you have to recover lordosis. So we agree with those inconvenience. And even though you can do it in a minimally invasive fashion, probably having less complications in the immediately post-op period. In this patient, we have a lot of complications related to non-union and junctional problems. So in this particular patient, we try to use a more minimal invasive procedure. In this case, we perform a discoplasty on the 2 levels that have the most remarkable accordion phenomenon, those changes in the in axial loading. Here you see some pictures of the technical procedure. This is what we do. So let me show you the post-op immediately image. Believe me, this is the same patient, probably with less pain. The patient is able to correct her position better. Let me put some numbers on this. The curve, remember, it was in almost 40, changed to 20. The sagittal imbalance that was 16 centimeters went back to 4 centimeters. So this is a comparison in the frontal plane. Even though we are not after the correction, really, the correction is a secondary benefit from stabilizing the disc that stopped collapsing when the patient is standing up. And the most important correction, here you can see it on the sagittal plane, she went from 16 centimeters to 4 with a procedure that is ambulatory and has really comparison with the option of deformity correction surgery. You can imagine that is much, much less in relation of complications. So the pain, of course, didn't disappear completely because we didn't take care of all the pain of the pain producers, but the VAS score went from 10 to 3, and the radicular pain went away completely. And this is her 1-year follow-up, that you can see that her numbers remain the same. We can close here the discussion if you want with questions.
Marcelo, there is a question from the audience. Couple of questions are there. How much cement per level, and have you seen any radionecrosis of the adjacent vertebral body following discoplasties?
We have been doing discoplasty for the last, I think, 6 years. We have a couple of 100 patients, so we already saw all the complications that are described and some that are not described. Sclerosis, osteonecrosis adjacent to the cement, we didn't see it. You have to take into account that we do this only on patients that are above 70 years. And the amount of cement we use depends on the amount of, it's not a fixed number. That will depend directly on the amount of opening of the disc we obtain on the operative table that Gaston shows us before. Usually it's between 2.5 and 4.5 centimeters.
Okay. Thank you very much. I think we'll move quickly to the last case of the session, Dr. Shankaracharya. In the meanwhile, I would like to welcome Dr. John Lowenstein, who has just joined us. Dr. Lowenstein, welcome from the Association of Spinal Surgeons of India, sir. We are running about 10 minutes late, so I'm afraid you'll have to wait a little bit.
Can you see my screen now?
Yes, we can. Go ahead, Shankar.
Okay. Sorry about that. I think I was not upgraded as a panelist, so I couldn't share my screen. Anyway, so this is a young girl, 14 years, with no comorbidities, came to me with neck pain and difficulty. She came to me a little later, but she complained of neck pain and difficulty to move for 2 months, dull ache around the interscapular region for more than 6 months. And though she had classical symptoms of fevers and some weight loss and decrease in appetite, her parents did not seek any medical treatments till 2 months ago. They live outside Delhi, so in the periphery where Maruti is located, and she visited a local hospital center, and she was empirically diagnosed at pot spine and given empirical treatment. So as you know, in India, we get 4 drugs and then 3 drugs for 10 months. So she was started on 4 drugs, and on examination, systemic examination was normal. She had a very small kyphotic deformity of the cervicothoracic junction, which was tender really, and she was not moving her neck much. She was very, very afraid to move her neck at all. And she had early spasticity signs, and Babinski test on bilateral lower limbs was positive actually. So this is quickly the pictures. I've put in the X-rays and the MR picture as well. So as you can see, she was already on empirical treatment of tuberculosis for 2 months. She had not improved. She has a T2 collapse, T2 an upper body of T3 and T1 lower body, and there's a large abscess with some kyphosis. So with this, and I've shown you the blood test, nothing specific apart from a raised ESR and some CRP. Otherwise, she was normal. Nutritionally, she was normal as well. So can I ask the panelist, can I ask Basu what you would do? I counseled her for Halo AA, but I would ask the panelist, what would you do? Non-operative management and continue ATT, or would you get a biopsy and then do ATT? Would you get a biopsy, Halo and ATT, or would you do surgery? And if so, what surgery would you do?
So before proceeding further, if she is not improving, even after a month or 6 weeks of antitubercular therapy, 2 months, so that means it's time to sit up. Sit up in 2 things. Firstly, whether there is any instability going on or not. For that, a CT would be ideal to see the amount of bone destruction. If the amount of bone destruction is significant, more than a couple of vertebral bodies gone, then it's time for intervention, surgical intervention for me. Any other panelists can give in their opinion, please.
Marcelo, what do you want to say? Anything?
Soumyajit, what approach will you take? Anterior, posterior, combined?
I would do a posterior only. If the CT, I suspect that the CT would show me 1.5 to a couple of vertebral bodies lost. So I would definitely do it posterior and do a cervicothoracic instrumentation with tapered rods. And by bifacetal approach, I go in from the posterior into the anterior hospital cord, take out the granulation tissue. I suspect that there would be no pus. There would be more of granulation tissue. I would try to avoid a laminectomy. If necessary, I'll take out a couple of facet joints and then go in anterior to the cord on both sides, do a thorough lavage, collect enough material for biopsy, and that's it. Do a posterior stabilization, posterior fusion, and wait and watch.
Marcelo, you were answering, is this a common problem in Argentina?
Well, I mean, I'm ashamed of speaking about this with a more renowned expert in the world, but I can tell you that in this particular case, with this type of destruction, with deformity and with cord compromise so severe, I have no doubt that the patient needs surgery. I will go from the front, make a one level and a half corpectomy. Since the sternum is so low in relation with the thoracic spine, I think that everything can be done from the anterior aspect of the spine.
Right, lovely. So we've got 2 different opinions. Basu, who wants to do all
and compressive injury at the very at the transition, a very dangerous transition, the cervical-thoracic transition. I prefer to do the circumferential approach by posterior, and try to reduce and try to remove the posterior lamina, and then by a posterior approach, try to go to the front and to do the rest of the decompression and the reconstruction of the anterior part.
Right. Thank you very much. So we move on. Shankar, what did you do?
Okay, so I think we have discussed this already. And so I thought that since the sternum is low, as Marcelo said, and I looked up the literature, and normally when the sternum is low, I tend to go anteriorly because posteriorly cervicothoracic fixation, especially when you put in lateral mass screws, the fix is not too well and you're never confident. So I always like to do a circumferential surgery in these low cervicothoracic ones. I put an anterior bone graft and a plate and then posteriorly. Of course, since the sternum was low, I was tempted to do this anteriorly, and there was no, I thought I don't have to do a manubrectomy or a split sternum. So this is what I did. And interestingly, as I went into the literature after a complication, which I'll discuss, you can actually go into up to T3 from an anterior without splitting the sternum or manubrium by actually having there are three corridors and there in which you can approach. And this paper has done about 150 cases by CT analysis and then doing them. Of course, I was not aware of this paper before, and I had so I didn't do a CT, and I went ahead and did an anterior surgery. So we did an anterior T1 to T3 fusion with an anterior iliac crest graft, and then I supplemented it posteriorly. The total period was 8 hours, anesthesia time from induction, positioning, then doing the anterior work, taking the bone graft, and then positioning the patient posteriorly, and then doing the posterior surgery. Posteriorly, of course, I didn't open anything, and I just fixed it. Intraoperatively, there was no problem. The patient did well. And extubation was uneventful at 8 p.m. From 9 p.m., her BP started rising, and it recorded. She was a young girl, as you know, so normally BPs are not high in them. And the highest recorded was 160, and the pulse was also high, and normal respiration and oxygen saturation. First post-op day, the BP still remained higher, and the heart rate had increased to 150 beats per minute, and urine output was 1 ml per kg. And they started Inaugural, so our ICU consultant started on Inaugural of physicians. When she complained of weak voice, she was still able to speak a little bit with dysphonia, and she had a weak voice. On the 5th post-op day, due to persistent low voice and dysphonia, I called the ENT surgeon because I was worried. We had put in a Riles tube. And then the ENT surgeon did a laryngoscope, fiber optic laryngoscope. And he said there was total bilateral paradoxical movement on phonation, and there was bilateral laryngeal nerve palsy. So that really put a fright. And he said that we may have to do a tracheostomy because this seems to be bilateral and they are serious. So I land up with 2 complications. One is a bilateral vocal cord palsy due to recurrent laryngeal nerve. Though during surgery, I did, apart from probably a little more retraction, there was nothing untoward during the surgery. And then I had a temporary baroreflex failure. And this has also been recorded in anterior surgeries of cervical spine. And that you can get suddenly abnormal blood pressure and heart rate. We gave her prednisolone on decreasing dose, and the ENT surgeon said, if you want to avoid a tracheostomy, we can wait a couple of days because the patient is not aspirating as on Riles tube feed, and then started speech therapy. Only after the 8th day, the blood pressure normalized to normal dramatically, and the heart rate decreased. And we, on the 11th post-op day, we did a fiber optic laryngoscopy again, and noticed improvement in vocal cord tonation. We then discharged her on 13th day and kept the Riles tube, explaining that the voice will probably come back because I was very reluctant to do a tracheostomy, and having read the complications after the surgery, I was really frightened as to what would happen. Due to lack of time, I won't go to this baroreflex concept, but it is a negative feedback to control the blood pressure, and if it gets depressed, then you can have a high blood pressure and high heart rate. There have been only 2 cases reported apparently from the literature. This also is not common, and most of them have been described in cervical myelopathy, post-injury, there's one, and fracture dislocations, but none have been described from a routine case, elective case of instability due to tuberculosis, and there have been very few cases of bilateral vocal cord palsy. And it is a life-threatening complication, and 4 cases have been described, of which 1 died and 1 had permanent tracheostomy and 2 recovered. So there have been also some cases described after laminoplasty, and they say the flexion of the cervical spine can cause laryngeal edema. Normally, as a routine, we also deflate the cuff of the endotracheal tube on all cervical spine surgeries, and we measure the cuff pressure and keep it below 20 to 24.2. And so that is routine practice in our all cervical spine cases. So that also is important, but we have done this in this case also.
Thank you, Shankar.
One second. I will tell you the latest. There are many surgeries available, and this is the last video, 6 weeks.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So you can now see after 6 weeks, she has completely recovered. And that is how I saved my skin, because this was a big complication. And since this is the first time I encountered this complication, I thought it would be nice to present this. Any comments from anybody in the audience on the panelists?
I think that was an excellent case, Shankar, but due to the paucity of time, I don't think we can go ahead with a lot of questions. But one final comment from my co-moderator, and then we'll hand it over to Gautam. Again, thanks for presenting this excellent case, Shankar. Really bilateral vocal cord pulses, I have never seen one. Thanks for educating me.
Yes, again, the same. Congrats, was a really interesting case. We learned a lot of things. It's nice to learn from the problems of others. that usually is really nice.
I have a lot of problems.
yeah, but that is really nice. You know, in name probably of Juan Pablo Bernasconi, Marcelo Gruenberg, Matias Petracci, Gaston Camino, and myself, thank you so much for this nice opportunity to learn from you and share experience from you. We have always have plenty of friends in India, and we are a really small country compared with India, and we learn so many things from you. You are really, really amazing every time we have this opportunity. So with any doubt in any of all of us, thank you so much for this beautiful opportunity.
Thank you to Dr. Basu and Dr. Emmerich for moderating the last session. I thank the speakers in the session, Dr. Gruenberg, Dr. Petracci, Dr. Shankaracharya, and Dr. Satish. All 4 cases were excellent with great learning points. This brings us to the end of this combined session. Let me start by saying personally as to how much I've enjoyed this session today. Right from the early lectures by Dr. Emmerich on cervical kyphosphiosis and cervical myelopathy, to his posterior line, which he described for us to be able to diagnose the problem and decide on treatment, to Dr. Bernasconi's lecture on the double rod technique in adult scoliosis, to the discoplasty technique of Dr. Camino, and subsequently the 2 case presentations by Dr. Emmerich, by Dr. Gruenberg and Dr. Petracci. All of them were fantastic, had fantastic learning points. And I think as a group, as a whole, ASSI has gained from this interaction with you. I thank each and every one of you wholeheartedly for your participation today. And on behalf of the President, Dr. Chabra, I hope that we will continue to interact in the future on many more occasions at many more fora, and hopefully establish a continuing link between SAPC and the ASSI in the years to come. Some final words from Dr. Grunberg and Dr. Bernasconi before we end this session.
For me, Gautam, there's no much to say. You say everything, and Juan Pablo make a very nice idea of what really feel by working with you. So thanks again. Thank you very much.
Dr. Bernasconi?
Yes, thank you. Thank you very much. The same like Marcelo, for us, for the Argentinian Spine Society. It's a fantastic opportunity to link with you, the India spine surgery. So I am really appreciate the situation, the participation in this meeting. Thank you very much.
Thank you and namaste and good night from India. We would be, I mean, if you want to stay back, if you have the time, I know it's a working day in Argentina. We've got some exciting interviews lined up. And to moderate this session on the interviews, I would like to request Dr. Gururaj and Dr. Rushma Tandon to take over the show and lead us through this very interesting session on the legends or journey with the legends in spine surgery.
Good evening, everyone.
Thank you.
Yes, ma'am, you can go ahead. Pushpa, ma'am.
Yeah. Good evening, everybody. Thank you, Gautam. Thank you so much for inviting us to start this session. And this is going to be a wonderful session. And we have some legends of spine surgery, people we look up to, people we learn from, people we have always been listening to and reading about and reading all their lectures and learning their techniques and improving our own. And so we have these pre-recorded interviews, and then we will be taking questions from the audience as well as interacting with them. And I would now, I think, like to invite Kshitij Chaudhary to start off with Professor Lonstein. John Lonstein is already here with us. Welcome to this session, sir. And Kshitij, I hand it over to you from here.
So thank you. Thank you, chairpersons, for this opportunity. Dr. John Lonstein and me, we have pre-recorded this interview yesterday. So I'd request the audience, the tech team to play it, or I can play it, either way. So welcome everyone. On behalf of the Association of Spine Surgeons of India, a warm welcome to Dr. John Lonstein. Dr. John Lonstein needs no introduction, as he is truly one of the legends in spine surgery, and I am honored to be given this opportunity to interview him. He, as a part of the famous Twin Cities Spine Center, has the world's oldest fellowship program, the John Moe Fellowship, that has trained over 189 fellows from all over the world over almost half a century. In fact, many of his fellows have gone on to establish their own fellowship programs and have propagated his teachings far and wide. He has over 150 peer-reviewed papers, and many of them are seminal works which have furthered our understanding of spinal deformity. He was the editor of the famous Mohs textbook, the first ever comprehensive textbook on spinal deformity. He was the president of SRS in 1991 and 1992 and received the Lifetime Achievement Award from SRS in 2015. Right now, he's retired and enjoying a retired lifestyle for the last 6 years. However, the teaching and the research continues. He's currently the editor-in-chief of the Spinal Deformity Journal. So I welcome Dr. Lonstein, and without much ado, let's ask him some questions.
Just, Casey, you need to change that slide. We've had a fellowship program since 1972, so it's 49 years.
Oh, okay.
48 years.
49 years. So that's why I wrote the plus sign. I did not know exact number. I knew it was more than 43. It was probably 43 when I was. But did you expect that you would achieve so much in your lifetime when you started?
No, you never can see what the future is. You can only see the present and the past. The future is unknown, so no, I couldn't expect this.
So, but did you achieve whatever you desired, or you have any regrets?
I have no regrets. Obviously, some of the papers I wrote, I wish I had expanded them, but it wasn't possible in those days to expand them.
So I understand everybody knows from your accent that you're not from America and you immigrated from South Africa. And I understand you were married and with a very young son, a newborn son at the time you immigrated from South Africa. Why did you choose general surgery? I see that you did 2 years of general surgery before switching to orthopedic.
Because when I left South Africa, my aim was to become a heart surgeon, a cardiothoracic surgeon. And then when I went to Boston, I did my general surgery residency, and I found that in those days, just the beginning of open heart surgery, it was you take the patient to the operating room in the morning, you do the procedure, and then because you had a problem like a leaking suture line, you take them back in the evening. So to me, orthopedics appealed to me more because you get somebody, for example, with a hand injury. It was easy to decide what was wrong with the hand, but what you did with the hand and how you reconstructed it depended on when the person you were treating was a laborer and needed a good grip, or was a musician who needed good mobility of his hand.
Were you influenced by Christian Bernard, who did the first heart transplant because that was in South Africa? Was it at that time?
Correct. Yes, I was. Obviously, we all were, and I was influenced on wanting to come here and do cardiothoracic surgery.
But then you switched over to orthopedics, and then you landed in Minneapolis.
Yes.
So
yes.
How did you meet this group? So I understand Dr. Moore recruited you to join his practice. So how did you meet John Moore?
Well, when I came here in 1969, Dr. Moe was the head of the spine service. We had a spine service at Fairview and at Gillette, and Dr. Winter was head at Gillette. And then when I finished my residency in 1972, Dr. Moe and Dr. Winter asked me to join them, and then we formed the Twin City Scoliosis Center.
So you were the chosen four of John Moe, the Holy Quartet, if I may. You can see here in the photograph, Dr. Winter, Dr. Bradford, and Dr. Ogilvy. Dr. Moe must be having very good HR skills to have all these four great people join him into practice. All of them were once point in time SRS presidents.
I don't know how Dr. Moe chose us and how it happened, but it happened.
So what was the mission statement of the Twin Cities Spine Group? What was the aim?
We just wanted to set up a program to treat spine deformities most effectively.
So in the beginning, what were the hurdles for setting up such a program? What were the problems that you faced?
Well, we were at two sites. We were at Fairview and we were at Gillette. So one of the things was to get all the information together. And we started at Fairview. I started a database that put all the patients into the database, operative and non-operative, so we can follow them. And then that was the beginning of our record system.
So I remember you showing me those punch cards that at that time to keep a record of all these patients. Did that happen during
Yes.
that time?
Yes, because in those times there was no such thing as Excel. In those times, we had to put in the information with punch cards, which were fed through the database system into the mainframe. And then if we wanted to ask any questions, they'd have to go and do the work for us. It wasn't like today where we can input the data and then ask the questions ourselves and analyze it. In those days, it all had to go through the programmers.
You have had many key contributions in literature. The most famous ones have been the natural history and growth prediction of AIS, bracing, school screening. Which one of these works do you think is the most important one that is most closest to your heart?
I think the natural history study, because that's the one. Natural history and bracing are the two. Firstly, bracing, we showed that bracing works, but the natural history study, because that's the one that people have found work is most useful in putting down the basis for prediction of curve progression.
So do you think over a period of time we have had more information about prediction of progression, or is this information going to change in any way in the future? Are we going to get better at it?
Yes, we are getting better at it, because when I did it, all we had was a RISA sign, other growth things you can measure an X-ray, menarche, and bone age, which was very, very rough. And now we're getting more clear and with better data using the Sanders information of hand, bone age, and the proximal humeral growth predictions.
So do you think these non-fusion surgeries, if we are able to predict growth better, would have some future for AIS?
Time will tell. Time will tell the role of the non-fusion techniques, because at the moment, it's the pendulum is swung to the fact that a lot of people, a lot of children get the non-fusion techniques who don't meet either the FDA or the IDA criteria. And we probably in the next 3 or 4 years, we'll better define who is the best candidate for non-fusion surgery. And then time will tell what the results are. In other words, does it really work?
So it's best not to jump on the bandwagon right now.
Well, if you jump on the bandwagon, you must jump on with your eyes wide open. So you collect your data and analyze the data, not only seeing what the literature says, but seeing what your data says.
The bracing, in spite of so much work done on bracing that it is effective, why hasn't it caught on so well in different parts of the world? Like even in India, it is not as common to brace.
Because it's very difficult to brace. You've got to have a physician who believes that bracing works, but more importantly, you've got to have a good orthotist who can make the appropriate brace and work with the physician to get the best results. And the other thing is it's very, very time consuming, and it's much easier to do an operation than to brace somebody.
And in India, we don't have a school screening program. And the main problem in our country actually is that even if we have a school screening program, where do these children get referred to? We don't have a knowledgeable healthcare system where they will have access. So with that in mind, what message do you have for our spine society to improve the care of spinal deformity in India? What should we be doing? We see a lot of neglected patients.
Well, do you have a system in India where children go in for annual physicals before they go to school?
No, we don't.
Well, there's a problem. If there is no system for the children to be seen on a regular basis, then there is no way for them to be detected early. The only other way you can do it is to try and get the parents more aware of scoliosis. But the trouble is, India is so large,
Correct.
and it's difficult to get the information out to the parents.
So coming to the Mohs textbook, this was the first spinal deformity textbook, and this was one where the knowledge of Dr. John Moh and all of his 4 disciples was spread all around the world. And you were the editor-in-chief of the last edition. And actually the principles outlined in these editions are still valid today. And I have heard you say so many times to study the principles rather than the methods. These books are out of print. Will there be a new edition?
No. No company. There are many other textbooks now of spine deformity. My statement about studying principles rather than methods, a mind that can grasp the principles will develop its own methods, is not, I didn't originate that. That was originated by Dr. A. Bruce Gill in the 1940s. He was president of the AOA and the Academy, and I think in his Academy address, he presented that as the basis of his talk.
But I heard it first from you, so I'm going to always say it's because of you. So this fellowship program, it's one of the longest. It is the longest uninterrupted fellowship program in the world. And the first fellow here, I can see, this is a picture I took in the library from the Twin Cities Center. Claudio Pedras, he was from Brazil, is that correct? 1971.
Correct.
And you are
correct. He came from Brazil at the same time as Ed Dawson came from Los Angeles, and they both did a fellowship.
And the program has always maintained this tradition of getting at least one foreign person to train at the center. Is that a conscious effort that you took to train people from outside North America, or it just happened?
No, we did conscious efforts when we got somebody who came to us from from outside the US. We offered them a fellowship because we wanted to spread the word to other countries in the world. So that's why we did that.
So many of these fellows you have had have themselves established very famous fellowship programs of their own. And many of them have gone on to become SRS presidents. So how did you cultivate a program which generated so many leaders in the field?
What we did was we just chose the best fellows that we had that applied, and then gave them the best training we could. And then that landed up them going back home and either just practicing or starting fellowship programs.
So this is one of the photographs of one of the years of the fellows. This is the farewell party where the attendings get to strangle the fellows, and here in the corner I can see you strangling Todd Albert, who later on became one of the SRS presidents a few years ago. So this is a nice tradition that you have. This is one of the surgeries I assisted you in. This, like, the implant density here is like next to nothing. And these are stainless steel rods. And this is a very inexpensive construct and very appealing for someone working in India. You know, we have a big cost constraint here. What do you have to say about these modern instrumentation with DVRs? And, you know, I mean, I am myself guilty, in spite of learning from you, to, you know, use much higher metal density than I've seen you use. So where do you think this is heading?
Well, the thing today is that because pedicle screws are very, very valuable, but they're not. The trouble is it becomes a technique that's used for everybody. there are many, many cases of adolescent idiopathic scoliosis that will be adequately treated by this technique, which is much lower density, which is very secure, and does exactly the same as the pedicle screws and gets a good result. But if you go to most training programs today in the United States, they are only shown how to put pedicle screws in. They're not shown how to put hooks in. You need to put in hooks even though you use pedicle screws, because if you've got a reconstructive case or a difficult case, you need alternatives. And the problem here, it goes to what is called primacy, which is the technique you first learn. For example, pedicle screws is the only technique, and that's the one you use rather than having other choices. It would be great if people varied what they use, but you go to any spine meeting today, and pedicle screws is the only fixation system you see.
This is one of the quotes by one of a fellow from Twin Cities. 1 year at the Twin Cities Scoliosis Center was enough. I personally don't think it is enough. I wish I could download your brain and ask you more questions than I already did. But it is true that the insight or the learning that was given, that I could teach myself, is a very important lesson that you give your fellows. I'll end with one of these favorite sayings of yours. We call it Lonstenisms. I'm not sure. I got this from Dr. Pera. He used to say that, these things are called Lonstenisms. But I have written quite many of them, but this is one of my favorite. This quote attributed to only you and no one else has to be heard in a South African accent to get that effect. So I would ask you to end with this. So can you read it?
There is never a never, and there is never an always. And remember, that is always true.
Thank you, Dr. Lonstein. Thank you very much for this interview. Thank you, Dr. Lonstein. And
Dr. Lonstein is with us here live. So if there are any questions from panelists, audience, please feel free to put them through to us.
I'll ask the first question. Since I have had the honor of interviewing him, Dr. Lonstein, in your career, which case do you remember was the most challenging or the most difficult one that you have ever done? Or let's say, which one of the pathologies that you treated were the most difficult ones that you did in pediatric deformity?
I think one of the most challenging cases I did was an adult with neurofibromatosis who'd had a previous fusion and had long Harrington rods from the thoracic spine to the pelvis, and all the vertebral bodies in the spine were eroded. There were numerous pseudoarthroses. There was very little bone present, and the rods were in the dura, compressing the cauda equina, and this patient needed a number of surgeries to get rid of the problem because she had meningocele that extended down to her sacrum, and reconstruction with a number of anteriors to get a solid fusion.
So I would like to see that case. I know you were trying to show me this last night, but Dr. Gautam Zaveri has a question for you.
Yeah, Dr. Lonstein, the question is, you worked at a time when medicine was not so advanced as it is today, and therefore probably complication rates at surgery were higher, and at the Twin Cities Center, you had the worst of deformities from all across the world which came to you. How did you deal with the complications when they occurred? I mean, Did you ever feel I want to give up the knife and stop operating when these type of complications, sometimes horrendous complications, did happen?
No, we did not, because we try to plan ahead to try and minimize the complications. We try to do surgery as safely as possible and not try and do things that were way out. And then when we had complications, we just became obviously much better at dealing with them. Once the wake-up test became available, we used it routinely when we did any deformity case. And obviously, when neuromonitoring came in, we used neuromonitoring, but didn't forget the wake-up test because that was always our backup.
Do you think in these days with neuromonitoring having significantly improved, a wake-up test is still necessary?
I think when you are questioning a result where you have loss of function or changes in your monitoring, I think the anesthesiologist must be able to do a wake-up test. And the problem is, a lot of surgeons have never seen it, and a lot of anesthesiologists don't know about it.
Right. Any other questions from any of the panelists?
Can I ask one question?
Yes, Guru, please go ahead.
Dr. Lowenstein, what is one message you want to give it to the present generation deformity surgeons?
Well, if the one message I give is the one message we give, this is the message we used to have written up in our conference room, and it's the statement from A. Bruce Gill. The surgeons must study principles rather than methods. So if you know the principle of dealing with the case, if the methods change, you can still deal with it. For example, I always like to quote, if you see a crooked bone that needs straightening, you know it needs an osteotomy. But over time, the techniques to do the osteotomy and the techniques to hold the bone have changed. But the principle of needing an osteotomy and fixing it and stabilizing it afterwards doesn't change, and the same as with spine surgery.
Right.
Thank you.
All right. Thank you very much, Dr. Lowenstein, for being with us. For us in the Association of Spinal Surgeons of India, to see a legend like you in person, a person whose books we have all read and grown up, is immensely gratifying. Thank you for spending your time with us, and we are extremely honored, sir.
Thank you very much. Namaste.
I would like to thank Dr. Kshitij and Dr. Lowenstein for that beautiful interview. And the next is on a very famous personality again, Dr. Lawrence G. Lenke. And we all know he doesn't need any introduction. I had a privilege to visit him and see his work. And once I came back, my thought process changed a lot. I call him a magician. So over to Dr. Soumyajit Basu, sir, for Dr. Lenke's interview. Over to you, sir.
Thanks, Guru. Same with me. It was a pleasure to watch him at St. Louis. I just wrote an email that whether he could join or not. In the morning, he told me that he was very busy with a meeting which has come up just now. So I don't think he can join. But if he joins in the next few minutes, Guru, please inform me so that at the end of the interview, which is pre-recorded, you can have a couple of minutes with him.
Okay.
So the presentation can run. Deepak, you can start the presentation. Good evening. It's a real pleasure to go through this interview process of none other than Dr. Larry Lenke. Before going into the interview process, I would like to thank Dr. Lenke for accepting this interview at a very, very short notice. As you all agree with me that he's one of the busiest person in the spine deformity world. And for him to accept this invitation at such a short notice, I'm really grateful to you, Dr. Larry Lenke. Can you just make some first comments before I start the slideshow? And there we go.
Well, first of all, thank you, Dr. Basu, for even giving me the honor of looking and reflecting upon my career a bit, hopefully for the benefit of the younger surgeons that have aspirations to do complex spine deformity work. As I told you in through email chain, I'm not one to really want to reflect much on my successors or awards or trophies and things, because that doesn't mean as much to me. What means so much to me is helping patients, helping surgeons do better to help their patients. And that's why I'm honored to do this type of interview with you. So thanks again for the opportunity.
Okay, we'll go on with the slideshow. Okay, so it is a real pleasure to interview the living legend, Dr. Larry Lenke. The first slide shows that what happens if you type Lawrence Lenke. About 170,000 searches in 0.59 seconds. And that's what is the ripple effect of Dr. Larry Lenke. When I asked for his interview, he sent me a CV and said, Basu, this might help. And believe me, I couldn't get the guts to go through this CV because it is 290 pages. More than 500 published abstracts, more than 1,000 presentations. He has kept a meticulous record of all his fellows, which is more than 500 possibly, all his guest lectures, all his videos, all his patents. Before going further, Larry, how did you make this tumultuous effort of building up this CV?
Oh, I have a lot of help. Obviously, one of my keys, and I'll say this at the very end, is surrounding yourself with good people. Obviously, you have to put yourself in a good position, and you have to work hard. And it's easy to work hard if you enjoy what you're doing. So I've been very fortunate to have loved what I've done in my career, and also have surrounded myself with very good, hardworking people as well, which makes this type of productivity much easier to accomplish.
On a lighter note, Larry, if you type Lawrence Lenke on the Google, do you know what questions people ask? The first and foremost is, what's his salary? And the next one is, what's his age? And if you go down a little bit more, what is Larry Lenke worth? What net worth? I didn't know that these were the important questions which people asked.
Yeah, I asked my wife that, Basu. I don't know. Yeah, I don't even know that. My wife has all those as all knowledge.
Right. I'll just begin with my interactions with you. I do not remember whether I do not know whether you remember or not. Mm-hmm. I first interacted with you when I won a GOP fellowship in 2004 Buenos Aires SRS annual meeting. By that time, you had already become famous because your publication of the Lenke curves in EIS had come out in 2000. And it was a very oogling moment for me to stand beside you to take a photograph. And then only I decided that I must join you at some point in time. And the moment came in 2010 when I was a visiting fellow in St. Louis. And I cherished some excellent moments. This is one of the most difficult cases, and this is the only one spinal deformity I've seen in my life, in which the whole lumbar spine was translated anteriorly and the sacrum of the pelvis was behind, which was a 35-year-old lady with an in situ fusion. She had at 5-6 years of age, and these were the clinical photographs. And there, we did not have 3D printing at that time in my country, so this is the first time I saw a 3D model. And I don't know whether you remember this case. Does this ring a bell, Larry?
I do remember this. This actually is a publication. I did 3 of these, Basu, in the course of around 5 or 6 years. Posterior vertebrectomies for severe fused spinal apoptosis, and it's published in Spine Deformity. She's one of the 3 cases.
So it's one of 3 out of 5,000 spine deformities. I was the lucky guy.
Very unusual.
And the same day, believe me, it was your 50th birthday. And no holidays, no cutting down on OR schedules. You had a very long day, and then you were accosted with a cake. And the OR staff asked you to cut the cake. And before leaving to the clinic, you said in the corridor, Basu, I know I'm sniffing something wrong. And the clinic was cancelled, and there it was in the clinic with all the celebrations of your 50th birthday. Do you remember that?
I do remember the surprise. Yeah, I didn't expect at all, including my lovely wife and children were there. So that was quite a pleasant surprise. The best birthday
And in the lower picture, you can see that you're grinning and sheepishly moving out, embarrassed to the hilt, because you didn't know that your family was invited at all.
Exactly.
And then you were very gracious enough to accept my invitation, and within 2 years, you came down to a very small hospital where I worked, and we had the first of its kind Park Clinic update on spinal deformities. And this is a picture taken in my room, and I still remain grateful to you for that.
Right.
And then the big event came in 2014. You remember you came down for the SRS worldwide course, and it was fantastic that we had 10 SRS faculty. You can see Harry Schaffelberger, you can see Munish Gupta, Hilali Nurdin, Mark Wadenbaum, Steve Glassman, Marinus D. Cliver, and that was a fantastic show. And again, your lectures, your recorded versions in that course still comes up, and people praise the lectures which you've given us for that in 2014. And I'm proud to have you as the first co-author in this publication of an AO Spine research grant. Thank you again for guiding me to that. And I'm grateful to your contribution to Indian Spine Journal, the current concepts in level selection for fusion and AIS. So you get so many of these, requests across the world regarding contributing to various journals. And I've seen you hardly refuse your near and dear ones. And I'm again grateful to you for this.
Okay.
Tell us about your childhood, Larry.
So I was born in the south side of Chicago. The south side is kind of the rough side. The north side is the more affluent side. My parents were basically high school educated. I was the first in the family to attend college. My dad basically went directly from high school to working as an apprentice in a printing factory. So he was responsible for printing of things like Time magazine and Newsweek. There's a popular American magazines. My mom actually was a secretary for an orthopedic surgeon in suburban Chicago. And after school, I used to go to his office because my mom didn't want me at home. So I basically grew up playing around in his plaster clinic. And I used to work with putting plaster on my arm as a young child. So maybe probably my interest in orthopedic surgery began with that. I really enjoyed playing a lot of sports. I wasn't very good at it, but I enjoyed the competitive nature of sports and the teamwork of sports. And I also played a lot of chess, which I didn't realize probably was helpful in my future career as a spinal deformity surgeon, because as you know, a complex spinal deformity operation has thousands of chess moves that you have to plan real time and also sometimes change on the fly, right? So I think playing a lot of chess in my youth and my teenage years definitely helped me to develop the kind of mental fortitude and planning ability, I think, of doing spinal deformity surgery. The other thing I want to mention, this is kind of crazy, but there was a girl in my grade school that I went to grade school with for like 12 years straight. Her name was Susie, and I don't remember her last name. I don't remember much about her, but I do remember that she basically had a kind of ear on shoulder deformity. I'm getting old, I can't even put my ear on her shoulder, but she had probably a congenital, maybe clipophile, congenital type of cervical thoracic deformity where her ear was stuck on her shoulder. And she had very bright red hair, so it couldn't be missing. She used her hair to kind of cover her deformity because she was so offset. But all the kids made fun of her, and I really kind of felt sorry for her because she, it wasn't her fault that her neck was so deformed. But that was my first introduction to spine deformity. I had no idea what that was a spine deformity, but I remember that I really felt sorry for her. I also remember all the ridicule that she got from all the other students who weren't very nice to her. So maybe that in some way also made me somewhat receptive to the difficulties of patients with deformity. But I just mentioned that because I do always think of that now later in my life.
So do you still play chess in your leisure time?
I don't. I'm just too tired. I don't have enough mental energy. I did teach my children to play chess when they were growing up, but I honestly don't play much now. I think I have my chess during the day doing surgery all day long, right?
So you went to University of Notre Dame and then the Northwestern University Medical School, and then your training as well as you became an attending in St. Louis. Huge, long years. I think 18, 20 years you spent there.
Basically training nearly 30 years in St. Louis for 6 years of training and almost and 23 years of being and attending. So obviously, and I mentioned this, all these universities, these are obviously very, very regarded universities. And I was very fortunate, to get into Notre Dame, Northwestern, and WashU for my training, and then out of Columbia now, obviously. And again, just putting yourself in a good position, right? I mean, just very, very fortunate from the beginning to have my training and my work at such prestigious institutions, but not only for myself, but all the people around me that are
working 16 hours, 18 hours a day.
Yeah, it was true. The only thing that saved me, Vasu, was that I traveled a lot. So I would work for a week or two, and I'd go to a meeting for a couple of days, because otherwise I don't think I could keep the schedule up. But the bottom line is that it did allow me to get a lot of experience, as doing deformity. Experience means so much, and repetition is so vital, right?
One interesting thought came into my mind. When I was at the airport receiving you for a small spine conference at Kolkata, and when I was there in the airport and I asked you, how much do you sleep? And you said that it is 5 on an average, more towards 4.5 than 5. So you still sleep that much, or you increased your sleeping?
Yeah, I sleep a little more now. Getting not enough sleep is not good for your health, and I learned that the hard way. So I definitely suggest getting more sleep. We all know that, right? I mean, there's good medical evidence, right? But honestly, for probably 25 years, I didn't get more than 4 or 5 hours of sleep most nights. On the weekends, I would get a little more. But the bottom line is you have to take care of yourself, and sleep is important.
So to quote unquote, you have done the most number of spine deformities, and possibly you're still doing the number of spine deformities which is unparalleled in the United States. And I think I cannot be more grateful to you when I hear that you're the most prolific spine deformity surgeon in the entire US. Tell us about your cherished moments at St. Louis, and which mentor left the most indelible mark on you?
Well, obviously, I really gained my strife, my roots in St. Louis, both during my training and my fellowship with Keith Bridwell. Obviously, I definitely need to put him first as my greatest mentor. After Ron DeWald, after I met Ron DeWald as a medical student, and I trained with him as a medical student. He was at Rush University in Chicago, but I did a rotation with him for a month. Then he introduced me to Keith Bridwell in WashU, because as you know, Bridwell was trained by Ron DeWald. So that's the DeWald to Bridwell, now hopefully Lenke lineage that I'm proud to carry. Just tremendous memories in St. Louis, getting my initial foray into deformity through Bridwell, getting my own practice set up at the Shriners Hospital, at the Children's Hospital, at the Adult Hospital, having a tremendous opportunity at WashU, and tremendous people. Being from the Midwest of the United States, St. Louis and Chicago are very close to each other, so a very comfortable beginning. Great people. Washington University is a premier medical center. As you know, you visited me there. So nothing but great things to say about both St. Louis and Washington University, and obviously my greatest mentor, Keith Bridwell.
How long did you work with Keith Bridwell as a fellow or a resident?
Well, 5 years as a resident and 1 year as a fellow, so 6 years of training, and then I was with him for 23 years as an attending, so nearly 30 years, Basu.
So I was really proud to be in the department, because in that single department, you had so many SRS active members. I can see Dan Ryu, I can see Jacob Bukowski by your side, and of course, the great Keith Bridwell.
Right.
So this is a slide which you've provided me. And as you've correctly said, the deformity surgery can not only save lives in the pediatric kids, but also for the adults, it can optimize the quality of life. But in this scenario, and I know that you are a very, very, very stringent believer of the fact that everything can be done posteriorly. In fact, when I first met you in Washington, you said that I have not done an anterior surgery for the last more than 10 years, Vasu, and I still believe that posterior is the way out. So at this point in time, do you really feel that there is still a scope of anterior surgery in some specific instances?
Oh, absolutely. And, one of the issues with anterior surgery during the 1990s, and I performed a lot of it, was just the morbidity of the formal anterior open thoracotomy or thoracoabdominal approaches. Remember, these are big, open, invasive surgeries, right? And so honestly, I love doing the surgery. The surgery technically was phenomenal. I did my own anterior approaches. If I happened to tear the vena cava, I sewed it up myself. So I was a real surgeon. The problem was that following that big anterior surgery, we still needed to do a big open posterior surgery. So the morbidity for the patient was too much. But now, obviously, many surgeons are getting very facile at minimally invasive anterior surgery. So that definitely has now sparked an increased role for anterior surgery and deformity. And obviously, I think that's great. My challenge then is to see, well, how can I replicate what people are doing from the front as well as from the back, minimally invasively, and do it from the back from a more open approach, but decrease the morbidity to make it more equal, right? And that's my challenge. And also, I must suggest that in severe deformity, especially when we're doing things like vertebral column resection, we are doing anterior surgery. I work in the anterior spine a lot. I just do it from a posterior reach around approach, right? So it's not like I don't do anterior surgery. I just don't come in from the side or from the front. I just come in from the back.
So you've dedicated your career to severe deformities. There are a few examples. I've seen a lot more in your slides, which I've been hearing intently for the last 10, 15 years. Tell us about the worst case. What went wrong and how did you cope up with?
Obviously I've had several, paraplegics, early post-op, most of them actually from either vascular phenomenon or like spinal cord strokes. I had one just 2 months ago, 8 hours after surgery with normal data, normal wake up in the ICU. The mean pressure just dropped a little bit and became acutely paraplegic. So, those are crushing problems, right? Especially when there's no consistent mechanical reason for that. But probably my worst case overall was a case probably 15 years ago in St. Louis. It was the mother of one of our infectious disease doctors who had a long-standing adult kyphoscoliosis, very severe, very rigid, but she's a functional lady. And I decided to do her in 2 stages just because she needed a very aggressive PSO, but also a T2 to sacrum procedure. She needed decompressions of stenosis, so she needed a lot of work. And she was a bit on the frail side. I think she's 60 years old, so I decided to do it on 2 days. But my mistake was that I did her 3 days apart. And so I did a Monday, Thursday combination. Monday surgery went fine. And Thursday morning, I saw her on rounds, and what I didn't know is that right after I saw her and before she got to the OR, she dropped her O2 saturations a bit, so she needed to be put on oxygen, and I didn't know that. So when we started the surgery, the problem was her lungs were already a little bit filled with some fluid and material. So we started the surgery, and immediately her oxygen saturation started dropping about an hour into the second stage surgery. And pretty soon, basically, she completely decompensated. Her saturations went down to the 50s. She coded. We performed a CPR. We cracked her chest. I got the cardiothoracic surgeons in. We did open cardiac massage on her for an hour or two in the OR, in my OR, and she expired during the surgery. And just a crushing blow. And I had to tell her son, who was an infectious disease specialist, that their mother had passed away during surgery, and just a horrible situation. But again, learning point is that now I never stage surgeons. If I do stage surgery, I don't do it that often, but if I do stage a very complex deformity, I have at least 1 or 2 weeks in between the surgeries. Their lungs have to be clean. Their mild coagulopathy has to be sorted out. So you want them fresher for the second stage surgery. And so I learned a very valuable lesson from that, unfortunately, and the patient had to pay the ultimate sacrifice, right, by her demise. But the bottom line is this is a tough business. If you aren't willing to kind of put up with these kind of complications, it's hard to be a complex deformity surgeon. But at the end of the day, we always need to use these type of horrible tragedies and any complications to make surgery better, right? We need to make ourselves better and do better for our patients. So that's why I've put a lot of emphasis. If you look at my CV, a lot of my papers are on avoiding complications, assessing complications, making surgery safer, because at the end of the day, we owe that to our patients, and I owe that to my colleagues to use my experience, to help others make surgery safer.
Absolutely. So let's come down to the earth-shattering classification system, which is undoubtedly the most widely cited spine deformity publication that has come out possibly in this century. So regarding this, I have two questions. What led you to think about the necessity of a new classification? And what is the future from a 2D to a 3D?
So basically, the impetus for this classification was that I was using the King system, obviously in my early career. And as we know, it's not thorough. There's some curves that aren't classified. Major thoracolumbar curves aren't part of it. Triple major curves. And number two is that we were trying to figure out, what's better for a thoracic curve, an anterior approach that Jürgen Harms was promoting, or a posterior approach that people like David Schuffelbarger was promoting, and we couldn't classify them reliably. I was in the Harms study group, and no one could agree on the classification. So I was thinking there as a young surgeon, saying, how are we ever going to figure out what the best way to treat something is? We can't agree on the classification. So that was the impetus to come up with a new system that was more reliable and more complete, obviously, for having all curves being classified. Obviously, we are moving towards 3D classification. The reason it's been slower, though, is that it does require 3D assessment, which it needs to be done either with CT scans, which is too much radiation, and now is still in the supine position, or with total body images through like the EOS system. But not everyone has that system, so there's a lack of input to allow for 3D classification. But as soon as that becomes commonplace, obviously 3D classification will become very common and used, as it should be, because obviously AIS is a 3D deformity.
So do you think that the 3D classification is the way ahead, but there are challenges regarding the infrastructure required to develop such a scheme?
Exactly. So as soon as infrastructure challenges are completed, then we'll have 3D classification.
Tell us something about the SRS. It has been a very, very long association which you had with the SRS heading committees, and I think you're the most frequently. You've been the nomination committee chairman, picking up the mentors and picking up the persons who would run the SRS, the leadership qualities you're identifying, and what makes SRS different from other societies. And if you could tell us a few words about the future of SRS.
So what makes SRS different, number one, are the people involved, and they're committed to spine deformity surgery. Spine deformity surgeons are a different breed, I think. It's tough surgery, right? I mean, it's the highest of highs and the lowest of lows at times, and it requires an extreme amount of clinical competence, an extreme amount of work ethic, time in the OR. You have to get things right. You can't skip steps in spine deformity surgery. Ultimately, your patient pays a price. So I think the spinal deformity surgeons are wired a bit differently, and we think differently. And to be surrounded with those type of people in the SRS is, to me, very stimulating. And that's why I think it's different than other societies. The future of that society, obviously, and it's headed that way. I tried to start it during my presidency, has become more global. I think you would agree, Basu, that many surgeons from India are benefiting from that. That SRS course in 2014 was one of the best courses I was ever at. Phenomenal attendance, phenomenal question and answer discussion periods, phenomenal interest, and I think dedication from the surgeons present at the meeting. So I think there's many other countries and surgeons around the world that will benefit from SRS engagement. That's slowly happening, and will continue to excel forward in the future.
And I have no hesitation in telling you that globalization of SRS was your brainchild, and as the years pass by, SRS is really, really becoming global. Now let's come down to the big move, the big move, the leap of a giant. The entire team moves out from St. Louis to New York. So what made you move, and why did you leave St. Louis, and how is New York different?
Well, I think it was a bit of a risk for me to leave St. Louis. As you know, I had a great practice there, right? Everything I needed. But why I left basically was for the profession of spine surgery. Spine surgery, especially complex spine deformity surgery, is a specialized area of medicine in surgery that really requires expertise and resource allocation from the universities and the hospital systems. And basically, Columbia University and the New York Presbyterian Hospital System were willing to commit resources to create a specialized spine hospital with all the resources and personnel needed for that, where St. Louis wasn't. And that's why I went. I didn't go for personal gain, because if anything, it was a risk that I wouldn't have the same practice. I left because to elevate the nature of spine surgery into those specialized areas of surgery like cardiac surgery, transplant surgery, that have always been received as needing a very large resource allocation, right, and specialized personnel. Well, guess what? Spine surgery does too, and we're proving it by our move to St. Louis, move to New York, and it's worked out great. I'm very, very pleased. It's been a great career move. Certainly, I miss my people in St. Louis. Obviously that goes without mentioning. It was a very hard move, and it'll always be a difficult move. But again, at the end of the day, if the profession of spine surgery, not only in the U.S. but in the world, benefits from it, then I'm grateful I made the move. And
I'm sure you now have a 10-surgeon consortium of spine deformity surgeons. And for the first 5 years, I think it was a challenge. Now that the COVID is really gone, I'm sure you'd be all the more blessed with the next few years of developing a fantastic spine hospital. I still remember your daily morning rounds. You start at 6:30 to 7. And I still remember your 27 years of weekly pre and post conference. And do you think in this context, when you're going through all these conferences and when you're going through all these rounds, do you really think that MIS is the future of adult deformity surgery? What is your take at this point in time about the mini-open anterior approaches or the minimally invasive lateral fusions?
Yeah, so I'll tackle the second question first. Yeah, obviously, as I mentioned, doing less invasive anterior surgery is certainly beneficial. Again, I don't do it, but my partners do. They do a very nice job. In their hands, it works. So that definitely is a huge step forward the last 5 to 10 years, development of things like L-lip and O-lip. MIS is going to play a role, for obviously more straightforward deformities, more primary deformities. I think I'm not sure anytime in the near future that complex resection type of surgeries are going to be best done through MIS approaches. I mean, and the reason I say that also is, I have patients that have just unbelievably extensive, all day spinal reconstructions. And within a few weeks, they're really doing pretty well. As long as they have a good attitude, the surgery is done well, the wound heals well. They really recover quite nicely. So although obviously it's always better if we can do things a little less invasively, I would say that a good open surgery in a very motivated patient can still have an outstanding outcome. And so that's why we shouldn't completely get away from open surgery, but we still should slowly improve on our MIS approaches over time. And I think there's going to be a melding of that over the next 10 to 20 years, obviously.
So your weekly schedule has come down from 5 ORs a week to 3 ORs and 1 day full admits and 1 day full clinic. So in a typical clinic on Wednesday, how many patients would you see? And how many of them are follow-up and how many of them would be new patients?
Yeah, well, pre-COVID, I basically had 2 clinics a month, seeing around 30 patients in each clinic, 5 to 8 new patients, and the rest follow-ups. I'm very fortunate. I only see new patients, follow-ups, and pre-ops, basically. All my patients are screened, as you know, even in St. Louis, I think when you were with me, you saw that. So I've got a very boutique kind of practice, and still have. So it's I can focus only on spinal deformity. That's very obviously very fortunate to have that kind of practice.
And what about Ron Lehman telling you that navigation and robotics is the future? Do you differ with him? Do you have a fight?
Oh, not at all. I mean, again, as soon as robotics are better and faster than me putting in screws, I'm using it. But right now, at least to the fellows, the fellows work with Lehman, the fellows work with me. They said it's going to slow me down still and not make me as accurate. But, again, there's no reason why the next 5 years we don't have a robotic arm that puts in 10 or 12 pedicle screws simultaneously, right? And then it's going to be faster and better. So that's certainly going to happen. I'm just kind of waiting for that day, and I'll let people like Lehman kind of sort out all the details until that happens, okay?
So next is, I know you love teaching, and within 2015 to 17, you have more than 100 visitors and fellows, and you meticulously have the 50 fellows pictures pasted there. Who was your most outstanding fellow and visitor? I know that you've more than 500 of them.
Yeah, well, the visitor one is easy. It's a guy named Dr. Basu from Calcutta, India. So, amazing guy. He was my most important and famous visitor. I've trained over 100 fellows. It's hard to pick out The favorites, obviously, people like Ron Lehman come to mind. I've stuck with me. Hanjo Kim at HSS is a phenomenal surgeon fellow. Mike Kelly, who's back in St. Louis, is a phenomenal surgeon and academician. So a host of people would come to mind. Steve Lewis, chief of deformity surgery in Toronto, Canada. The list goes on and on. But I'm very fortunate. I call them my extended family. Obviously, I have a wife and 3 children as my immediate family, and over 100 fellows that are my extended family.
So when you see your children growing up, by the way, tell us about your children. You have 3, I believe. What are they doing now, and how are they posted in life? So I'll start with my son, who's a middle child, actually. Brad is in finance in New York City, who's going to start Columbia Business School next fall, one of the top business schools in the world. So he's very excited about that. My youngest, second from the left in the far right picture, is Erin. She actually works for a company called Executive Search here in New York City as well. And her job the last year and a half has been to recruit nurses and therapists to work in hospitals. And guess what? With the pandemic, she's been incredibly busy working 7 days a week, 20 hours a day, because it's such a need. So she's keeping very busy right now, but doing a very good service to align nurses and therapists in the hospital positions. And then my oldest daughter, Lauren, is based out in Los Angeles, but she's been actually with Beth and I living with us since she got married in October. So she's recently married to a New York gentleman. And Lauren is a social worker. And interestingly, she is a graduate of Columbia Master's Program in Social Work. And my wife, Beth, is a current student in that same program, getting her master's in social work right now. So my wife, when I'm recording this live, is actually back at home on virtual school and classes for getting her master's degree from Columbia University in social work. So I admire both of them very much. Absolutely. So would you ever want to see your son or your daughter becoming a doctor? I'd love to do that. Unfortunately, I think they saw or they didn't see their dad home enough because of the hours I put in when they were younger. So none of them elected to go into medicine. I would have loved to seen that, but bottom line is I want them to do what they're happy with in life, and all 3 of them are very satisfied with their roles in life, and I'm very proud of all 3 of them. So your extended family include the colleagues and staff at WashU, swan surgeons around the world, more than 100 fellows trained, and more than 5,000 patients treated. This is your real-time hero, and I really wonder the excellent support she's given you over the decades that you've been with her. And as they say, that every success story has a woman behind. And I'm sure Beth is an extraordinary person, extraordinarily supporting you throughout these years to make you a living legend. Lawrence, and that's the most understatement thing you can say, Vasu, because so what you just said is so much an understatement. Beth is an amazing lady, amazing lady. I'm sure she's amazing, Larry. And we'll just talk a minute about the Lenke Family Foundation and giving back to the society before you tell us your last words, your confessions, and your message to the young surgeons. All of us in this profession are very fortunate, right? And I think it's important to give back in one way or another. So you can do it in many ways. You can do it financially, as Beth and I have done with our foundation. And you can also do it with service. I've done the outreach surgery in various locations around the world. And you just do it basically by volunteering in your local environment. Right now, especially around the world with pandemic, there's so many needs, right? Whether it's donating time to give vaccines or to give out food to those in need. I mean, we are all very fortunate. So in one way or another, please give back. And I guarantee you, it is true that giving back means so much more than receiving. You'll be the beneficiary of that. I wanted to read the young surgeon's message yourself, right? So my advice is to work hard, but make sure you enjoy what you work at, because it'll make that much easier to do. You need to surround yourself with the best and honest people and lead by example. You need to basically go about your profession with patients and your colleagues with confidence, by not being cocky or arrogant. That's not going to help you at all.
And my other quote is, "No one is perfect, but our patients deserve us to strive for perfection during our deformity surgery."
Thanks, Larry. And we end with your confessions.
As you can see, I tried to express that I am the luckiest person in the world. But interestingly, the harder I work and the better I treat people, the luckier I get. My other quote is, "It's certainly better to be lucky than good, but it's best to be lucky and good." So you need to get the training you need to do a good job with surgery, and your patients will benefit from that.
I would say, Dr. Lenke, that not only you're lucky and good, but you're good and lucky.
There you go.
And with these last statements, I think you've sent a very strong message to the young surgeons of India, and the confessions of legend are awesome. I take this opportunity to once again thank you, Dr. Lenke, for joining us, and it has been a fantastic experience talking to you, cherishing my moments with you for the last 30 minutes. Thank you.
That's
Have a very nice day.
Thank you. Good luck to the rest of your meeting. Appreciate it.
Thank you.
I think that was a lovely Basu. We should immediately move over to the next interview, where Kabhai Nene interviews our very own legend, our founder, president, flex secretary, Dr. V.T. Ingalhalikar.
A very good evening, everybody. And in this last session for Assicon today, we have with us a legend who has walked the walk, talked the talk, and arguably without him, we would not be here today. Dr. Vinod Ingalhalikar has been credited with the genesis, the very genesis of the ASSI and of course Assicon. And without him, there would have been no Assicon and no legends at Assicon. He's lived life king size. We know him as a person with great academic repute, but also a person who's delved into life as a whole. And what he's going to tell us is going to be most relevant to our scenario because he's born and raised in the same circumstances that you and me have been. So folks, hold on to your seats because this is going to be pearls of wisdom from our very dear Dr. VTI. Thank you, sir, for joining us. You're truly a legend.
Thank you, Abhay. I don't know whether I should be called legend, but I could be called a old man of ASSI.
You're a person
or a grandfather of ASSI at the most.
Stories have been made and you're going to live through the generations. You already have. You're a legend indeed.
I'm extremely happy sitting here today, not because you're interviewing me, but because ASSI has reached a pinnacle now. And look at today's meeting. We have people from all over the world eagerly waiting, eagerly wanting to look at things, and they have been moved to the screen all through the day, whatever the time in their country. I think it's a very happy situation for a person like me.
Absolutely. Thanks for that, sir. So we are all very curious to know, you started the ASSI and you were solely responsible for how things went. Can you tell us how it was right then at the beginning, so many years ago, so many decades ago when ASSI was just in its founding days? What was the response of the people and what work did you have to put in, sir?
Okay. Now, basically, it started, I was academically very active in general orthopedics. But during clinical meetings or clinical discussions, whenever the discussion would linger on for little more detail, the others would stop it. They would actively stop the discussion. Oh, you can discuss that later on amongst yourself. We don't want to hear that. I realized that a general orthopedic person or orthopedician was not truly deeply interested in deep deliberations. And I was kind of starving for discussion with people. There were a lot of people in Bombay that time, Dr. Chaubal, Dr. K.T. Dolakia, Dr. S.K. Bansali, Dr. Masalawala, Dr. Bavdekar, just to name few, and among neurosurgeons also, Dr. Ginde, etc., who did a lot of good spine surgery work. But nobody was allowed to talk and discuss. And I realized that unless we have a forum specially interested in it, these discussions, in-depth learning, giving, this give and take would not occur. 1983 in Delhi, there was a meeting on spinal trauma. It was the first major spine meeting in India. It was organized not by Medico, but by Major Ahluwalia, who was an Everest quadriplegic. And during that meeting, I came across a lot of people who had similar thoughts and interests. And we went ahead, and with the blessings of Dr. K.T. Dholakia, Dr. Chaubal, and especially Dr. Bowdekar, who was very actively supportive to me, we declared or sort of opened ASSI, Association of Spine Surgeons of India, on 18th December 1985 during YROC, which is Bombay Orthopaedic Society's conference during that. And believe me, right within first half an hour, we had 18 life members who committed to me within that moment. So the need was there. And again, after that, it was just a I would say gallop. In 1986, September, I organized the first ASSI conference. It was held in Taj, and we had managed to invite faculties from abroad, like Dr. Nakemsan and few other people.
What about the funding and the budget, sir? We are very curious to know.
Well, the total budget was 1,10,000. And with that, we could do it in Taj. And fortunately, the faculty those days, because of Dr. Dholakia's word and his credibility, they came on their own, except one person to whom we had to do small funding at that time. But the whole thing was, and the conference was attended by 160 people. Even then, the first conference of ASSI. ASSI is known for a good attendance in its meeting. Just prior to that, I did the first cadaveric workshop on spine at Sion Hospital. It was the first ever orthopedic workshops in India. I was inspired by ENT surgeons in our institution who were doing mastoid workshops. And I used to take my students to the anatomy hall for dissection and teaching them dissection. So almost 60 people joined the workshop way back in 1986. Thereafter, a lot of people from everywhere joined the stream. They eventually took over. And I'm very happy today that ASSI is a, what we call, very healthy, robust organization, applauded, respected, regarded all over the world by people of all levels and all levels.
You reap as you sow, they say, guys, and this guy has sowed the seeds, and we are reaping the rewards. We thank you so much, sir, for what all you've done. Just moving on to another very, question that comes to everyone's mind is that a lot of water has flown under the spine bridge over the last 30 or 40 years, and a lot of technologies and techniques have changed. The way we are treating pathology has changed. How do you adapt to this? What do you think is going to stay in the future? What do you think is the bogus technology that is flooding the markets? Can you give us some of your insights?
Okay. One thing is for sure that medical science is a flowing thing. It's not a stagnation. It's not like you have something regarded today as a concrete and that stays on. I think except basic anatomy and basic biomechanics related to gravity or a basic body's behavior towards healing, etc., except those things, all other things are fluid. The disorders, patterns, their presentations are changing. The management patterns are changing. Certain patterns are rapidly advancing, then shutting off, going back to the original level. Some of the technologies have gone out of vogue. Some new technologies have come. So I think this is something fluid which is going on. And if I have to do justice to the patient, if I'm practicing and I'm treating a patient, I must do justice to him. And I can do justice to him only by living alive with the current trends, the current knowledge, current technology. Whether I adopt the technology or not is up to me or every individual person. But any practicing person for the benefit of the patient and as a justice to the patient, he must be completely up to date and updated. He must, as and when possible, he must adapt to the new technology. He must. You can't remain stagnated. You can't remain stagnated. Should not remain stagnated. It's not fair to the patient.
I'm going to try to pin you down a bit, sir, because we want to hear this from you. Is there some technology that's going around that you feel is rather market driven and it will not stand the test of time? Instead, do you think there's some technology that you should have had, you wished you had 30 years ago, 40 years ago, which is a game changer?
Yeah, the technical tools part of the story, yes. The lot of cutting technology, the gadgets, the laser, the beams, the power tools, they all are useful. We lack them very badly, but we have adopted to them. They're good. Talking about market-driven technology, my guess is there's a fair amount of market-driven technology. Well, every manufacturer, every designer of a thing plans to make something better than what is existing. The point is that truly that effective, like what is said? Number two, is that cost effective? And number three, especially because we are working in India, is that can patient afford it? Is it affordable? And somehow my patients have always been from a lower middle class or lower class patient. I worked for a long time in a medical college, municipal medical college, and therefore my clientele has been by and large without much of a funding for them. So I had to keep on going out with the technology which is approved, confirmed, but I'm not against new technology. But market-driven technology, I think day by day, with the way marketing techniques and technologies or marketing trends are changing, it will happen more and more aggressively. It's up to us surgeons or end users to decide what is truly useful, what is truly not useful. Some people use it for one-upmanship. Oh, I was the first to do this. I was the first to use this. I don't know how appropriate that is. Or some people do, oh, I'm doing the most expensive surgery in India. I don't know how appropriate that is. But basically, it must be seen that one should be able to find out the good grain from the kernels.
Absolutely. Spoken like a true maestro, sir. Thank you for those insights.
And it's difficult to pinpoint that everybody would strive to market the technology. Only time will tell us, but we have got to be with the technology.
So in the sea of this lucrative technology and aggressive surgical maneuvers, you have been, sir, a torchbearer for conservatism. And right through your career, you've preached and practiced conservatism in spinal disorders. You were the first person to start a back school on this side of the Pacific, if I can be, if I'm not wrong. And you've been running it for decades. You've been, the formator of the injection techniques course. Your physical therapy department is extremely active and intelligent, if you may. Can you talk us through your thoughts about conservatism in spinal?
Okay, I'll tell you. My first teacher for my post-graduation was Dr. M.V. Sant. And he's supposed to be the father of rehabilitation and physical medicine in Asia. He's the first person to start a rehab center in India under the state central government. And during my early days, he insisted on my doing rehab course. He saw to it during my internship or my early trainingship, he convinced my other bosses to let me go away and attend those courses. So I did a course in physical medicine and rehabilitation. And I truly came to know firsthand that, look here, physical medicine is important, the rehabilitation program is important, surgery is only one act of a drama of 2 acts or 3 acts. The further part deserves rehabilitation. Then my teacher, my next teacher was Dr. K.V. Chaubal, top class surgeon par excellence, the neatest and the cleanest surgeon I've ever seen. And fortunately, I developed love for the surgery, not a hate for rehab, but equal love for the surgery. And I opted to restrict my practice to spine surgery. And that is how the whole thing continued further. There's another thing. During our residency, the rehab departments were under the umbrella of orthopedic department. And after every OPD is over in the afternoon, it was my job as a registrar to go to the rehab department, sit there for half an hour, 1 hour, sort out all their queries, give advices, etc. And this I did for 2 years. Every OPD, at the end of OPD, I would go and sit there. So I have seen and practiced rehab firsthand myself, though I have practiced spine surgery also. So it was never unimportant. Well, something happened. You will be amazed to know. I started teaching spine surgery. I conducted workshops. I did almost 65, 70 workshops. Then I realized that people have not understood the basis of spine. Like I did not understand basis of spine before I studied biomechanics. And then I started teaching people the basic understanding of the spine, the rehab processes, the utility, etc. So some people have commented, you got tired of surgery now, and now you want to do non-surgical care. So I answered them, I said, no. I could learn the technicalities of surgery much quickly and earlier. It took time for me to learn rehab process so long to understand it clearly. So I'm teaching that now.
Fantastic.
All in all put together, I'm very happy that the results I got in my practice, and a lot of my students learned from that. We conducted courses for 7 years. Talking about back school, it's a psychological need of every patient to know about his disease in detail. Every backache patient, spine patient will ask you hundreds of questions. So I started informally talking to them, collecting 3-4 people at the end of the day, talking to them. And eventually, over a period of time, I converted that into a formal thing. Same time in Hamilton, Canada, there was John Hamilton who had started Canadian back school. And Nakamson had a small back school that time. But ours was a back school which was far more in detail. It was done in regional languages, Marathi, Hindi, some sessions in Gujarati. And it was for 2 hours.
Such a futuristic thought, sir.
And we ran it for 29 years till the internet knowledge was percolated amongst the people, and they didn't. But even then, people still ask us, sir, we go to the Google and we go to net. We are not happy with it. We want somebody to tell us and explain to us.
Wish there was a Google Halikar amongst us, but you are one, and this has been literally a very forward thought so many years ago, and it's an information or a pearl of wisdom that all youngsters.
Another thing, talking about injection. I was invited as a guest speaker, American Back Society. Now, during that, there was a Kempin's workshop on endoscopy. I attended that. And I realized that endoscopy is something which will come to India later on, but it helped me to formulate my technology or my pattern of doing things. I also realized that a lot of C-arms during those days didn't have a very good pictures. So a lot of work was a guesswork, and I had to develop anatomy-based technology or techniques where even if the C-arm is not there or partially works and stops working or gives you poor quality images, still I could inject them reasonably successfully. And that's how people kept on coming and learning. And we have done a lot of
fantastic things. You've spent so much time and so much part of your life in spine that it's hard to imagine that you're the same guy who actually introduced the spinal community or the doctor community to a world outside your profession. Leaving aside any insecurity, you've dived into a life that runs parallel to your spinal practice, and you've been as successful in that And sir, I request you to tell, use the last 3 or 4 minutes of this chat to talk to us about and inspire us about your life outside of spinal surgery.
Okay, Abhay, all of us, all practitioners who treat patients and operate upon patients go through stress. Maybe occult, maybe overt, but we all of us go through stress. And we say, okay, at the end of, after another 2 months, I'll go on a vacation for 5 days. You get stressed every day. You can't have de-stressor at the end of 2 months or at the end of a year. Oh, whole year I'll work and then later on for 10 days I'll go to Switzerland. No, you can't do that. If you are stressed every day, you need a de-stressor every day. And if you can see your work email on weekends, why can't you see a movie on the weekdays? Why can't you do something similar? Music has been my love from beginning.
You're the famous composer of the ASSI anthem, aside from the Bombay Orthopaedic Society anthem, the IOA anthem, and the Bombay Spine Society anthem.
And I think music is one thing which will de-stress anybody and everything. I love singing. I teach music on the very heavy surgical day. At the end of the day, as a de-stressor, I teach music for 2 hours. 2 children, 2 elders. I have composed music. I have directed music. Taking care of my practice, I did a lot of extracurricular learning. One of that was doing a diploma course in music composition and music direction from music department of Bombay University. I also did a lot of yoga training to people. So these are CDs. I write poetry regularly. I write for stage. I write for TV serials. I have been awarded literary awards. I have started using music for my patients, and I use music for Parkinson's. I use music for other people, which is a very rewarding experience. I'm happy with that. Well, I had my tools lying idle, and I started using my bone skills on wood. I sometimes even harvest my wood. I have a farmhouse where I go and cut the tree branches and then I shape them out, work them out with the tools of different kinds. Well, working is similar to working on the bone. Look at this. Look at this small block of wood, which can eventually be turned into a beautiful lantern, or this block of wood, after processing further, can be converted into a vertebra. Well, 3-dimensional friendship with vertebra has helped me to cast out this. And this is to the measurement. And the good part of the story, when I say 3D friendship, when I was doing this, I had no vertebral modding sitting in front of me. It's completely out of memory. So you start with a plain blank and get on, produce something. Start with a small piece of wood, convert that into a beautiful swan. Start with something smaller, and again do wood carving. All this is de-stressing. And one has to remember that de-stressing is very important. See, you can have a plain simple block of wood, convert it into this using the tools of different kind. I also enjoy painting and drawing. On the cover of your cell phone, you can make your own cover so beautiful by drawing and doing things. I enjoy. The most important part of everybody must have some fine arts in his life. Everybody must have. It may be anything. It may be sports, it may be music, it may be reading, it may be playing, it may be game, anything, but you must have some fine arts in your life. And don't wait for it. But I'll start it from the 1st January. I'll start it on my next birthday. By the time you do that, perhaps you're earlier caught up by Alzheimer, or Parkinsonism or cardiac failure, don't wait for that. Whatever you want to do, start it today along with your today's orthopedic surgery.
We absolutely hear you, sir. All the insights have been so helpful, and you're truly a guy who's larger than life.
This is my own portrait I've created using digital technology. You were asking whether I adopt to the new technology. Yes, I do, and this is the thing which I've done.
I won't ask you that question again. I saw you doing a 3D CT printed vertebral body just now.
Without a model in front of you.
Without the model in front of you. You've used better tools than the laser cutters. So what can I say about the man who's really, like I said, walked the walk and talked the talk? Thank you so much, sir, for sharing your insights. 20 minutes is always too short for a person of your persona. But it's been a great pleasure. And Assicon 2021, thanks, Dr. V.T. Ingalhalikar, for sparing this special time with us. Thank you, sir. And
thank you once again. Thank you once again. And I must say here something. I'll fail in my duty if I don't say that. Though I started ASSI, I nurtured it for first 8 years as a secretary, then up the ladder further. But my followers have done excellent job. They have reached the shores of other countries. And today, ASSI is a respected body. And I think their contribution, all my followers, their contribution, and people like you, young Turks, young live wires, I think if we were not to have this ASSI would have been one of the aborted bodies, like many hundred bodies take a birth and demise.
Long live ASSI, long live VTI. Thank you so much.
Thank you so much.
Thank you, all of you.
Such a wonderful talk and session. So I think sir, in all your talk, we have forgotten to mention Madam Mrs. Ingalhalikar, who is the solid rock behind you.
One can't be complete without a spouse.
Exactly, and such a wonderful lady, so kind, so large-hearted, and like the father figure you are, she is. Like the father figure that you are, she is similarly like a mother figure to, I think, the whole society, looking after everybody. And the second question I would like to is that what opinion is the reason that women are not joining spine surgery, or not joining the association? Why is it that we are not able to garner interest among the female orthopedic surgeons? There are almost 350 female orthopedic young girls everywhere. And we are not able to get them into the organization, even though I am trying so hard.
Have you realized that amongst those ladies, majority are trying to go for pediatrics or hand or some such surgery? They don't even want to go for a trauma surgery as much, unless they're forced to practice a general orthopedics. So all in all put together, spine surgery is considered too arduous, too prolonged, too stressful, too complicated, which is truly not so. Well, it needs good amount of attention, needs a patience and stamina. There are two things one must have. You need patience and meticulousness. If you have that, anybody can become a spine surgeon. And ladies probably are inherently patient than gents are, and they should take up. I have talked to many of our orthopod ladies and told them, why don't you take up orthopedics? Why don't you take up spine surgery? And not really many. And if you see the world map of spine surgery, you will find about 6 or 8% women. So it's not only in India, it's all over. Though that percentage is improving, that is changing. I myself don't see any reason why a lady orthopedic surgeon or lady neurosurgeon should not take to spine surgery. They are perfectly capable of doing it. You are one of the examples for that.
Very attractive and leadership that's coming in. Dr. Basu, Dr. Gautam, and Dr. Shankar. I'm sure they're going to attract the female folk.
Thank you, everybody, for such a wonderful session. Thank you, sir. Yeah. Yes, sir.
No,
you were saying?
I thought I thought somebody said, would you like to give a message at the end?
Yeah, please do.
Yeah. Well, technology, everything is fine. We are probably losing touch with clinical science. And I'm very sad at that. I've been an orthopedic teacher for over 40 years now. And I realize that every next generation of students coming in or fellows coming in, they don't want to give importance to the clinical medicine. Probably we as teachers probably are not impressing enough on them that clinical science is needed. I have seen patients with 6 or 8 MRIs, but none of the previous doctor's prescription paper includes examination findings. And it's a very sad situation that the second thing I would like to say that before you take up to the spine surgery, first prove to yourself that you are a good general orthopedic or a good general neurosurgeon. Practice that solid for 5 years, 8 years, 10 years. Your maturity as a specialist, as a spine surgeon, will be far, far different than when you directly jumped into spine surgery. So that is something I have seen happening. And all those who have done good proper general orthopedics, good proper general neurosurgery for sufficient time. I have come across recently somebody who said, I'm endoscopic spine surgeon. I said, well, do you do open surgery? Sir, I have truly not seen open spine surgery. He said he assisted somebody or he called somebody because he got into difficulty. That person came and opened the case. He said that was one of my few episodes of looking at a spine open. I don't think that's a very happy statement I heard. So if we want, as it is, spine surgery is in disrepute. The moment you tell any patient that you deserve surgery, they'll jump away like a frog will jump away. And this will happen 90% of the time.
Sir, with these words of wisdom,
probably we are not.
With these words of wisdom from you, I think we'll call today's session to an end.
Thank you very
much, sir. Thank you, Abhay. Thank you, Rushma. Thank you, Gururaj, for moderating sessions. We've had a wonderful time, great learning, but we've overshot by about 15 minutes, and that's why. And we have an early start tomorrow again at 7:30. We meet with the ASSI plenary session. So please do join us tomorrow morning, another day of great academics. Thank you very much.
Good night. Thank you, everybody. Good night.
Gautam sir,
night.
Marathon from morning till night.
Yeah, he's been sitting all through.
I think
he's never absent from the screen.
3 days.
Really into the secret.
Gautam, did you have lunch, dinner, anything? Did you eat? Had coffee?
I don't know.
Well, great going. Thank you.
I'm having coccydynia for sure.
You can't have. A thinny person can have.
But I lost 44 kgs. No.
I know. You've done a commendable job of that. Okay. Right. Anyhow, it was a great day, greatly arranged, greatly organized. I admire all of you boys. I feel happy. Proud to be associated with you.
Thank you, sir. Thank you. Good night. Good night, everybody. Thank you very much for all the help in this and practically organizing Ankur, Neeraj, Guru, Janardhan. Very nice. Thank you very much.
Thank you, sir.
you.